Hello everybody, welcome to our September public board meeting here at Humber NHS Foundation Trust. I have two apologies for today's meeting from Stella Jackson and from Priyanka Pereira. I don't think there's any other apologies that I'm aware of. Declarations of interest. Are there any changes to the declarations of interest that anybody would like to make? And if you have got some, please also make sure you let Laura know and she can amend them in between our meetings. Again, as we normally say at these meetings, if there's anything on the agenda that is in conflict with one of your interest areas, please flag so we know that that's maybe an item you shouldn't be taking part in. You know the drill on that. Okay, let's move on to the minutes of the Public Trust Board meeting held on the 30th of July. Are there any corrections to these minutes, first of all? No? Is everybody happy to approve the minutes? Brilliant, that's great. Then we'll take any matters arising from the minutes or any matters from the action log and work plan. Anything from anybody? Steph?
Yeah, just a quick one. We've got a mapper on the work plan for this time. I'm taking it that's covered in the section within the Chief Exec's report that the Deputy Chief Exec has prepared. Is that correct?
Yes, it is. I think it's included in the Chief Exec's report. Yes, that's in there. Thank you.
Perfect. Thank you.
Thank you. Anybody else? No. Okay. Right. Thank you very much. So. We're a little ahead of time. Have we, Laura, got our colleagues for the patient story with us today?
Can't see them yet. I'll just drop them a line, Chair.
Okay. Well, I'll tell you what, while we do that, I'll do my chair's report and then just come back to that. So on my chair's report, item number 6, just first of all, I just want to say well done to everybody at Humber who's worked so hard. And that's been reflected. I know, Michelle, you'll want to say more about this in your report. Has been reflected that we have achieved the NHS England segment 2. We had as we all know, we had a really good get together on the 15th of September, where we were able to look at that, but also have a conversation about where were the areas where we feel we could make more progress to the next round of assessment in this space to move into segment 1. And we had a really good discussion on that day, but just to say well done to everybody who's worked so hard to achieve that. And we can see from the other trusts both in our areas and elsewhere that it is not just a given that this will happen. We are in many respects in a very more positive position than other trusts across the NHS. So well done to everybody. Before we take our colleagues for the patient story, I'll just finish off a couple of things. It's this time of year in the work plan where I have a look at the committee membership and also our champions and so forth. As colleagues all know, we're going through a process at the moment of recruitment for new non-executive directors. Obviously you can't replace him, Stuart, but Stuart will be leaving us in January as audit chair, but also a new Ned. I've made the decision, and I hope everybody is happy with this, that rather than change everything now, we'll keep everything as it stands. And I've contained all the details in my chair's report on that. And then I will have a fresh look once we've done the recruitment process and that's completed. Is everybody happy with that decision of mine? That's brilliant. Thank you very much. And just to add as well that governor election preparations are underway, and I look forward to seeing a number of you at our AGM and annual members meeting tomorrow at the Trust. Any questions on anything else in my report? No? Brilliant. Thank you very much indeed. So we will go back. Welcome to our colleagues here today. I'll let you introduce yourselves. We really appreciate, particularly when some of the people who use our services feel willing to come and speak to us about their experience and share hopefully what worked, but also if there were things that we as a board need to be aware of that may need some improvements as well. But we really do appreciate it, and I know it's not easy always to share some of your journey in this space. So welcome. I'm Caroline, the Trust Chair. Can I hand over to you to introduce yourselves? And I think we've got about 20 minutes with sort of 10 minutes and 10 minutes for questions and comments. So very much big welcome to the board this morning. And I hope we're not too frightening and off-putting. I hope not. Anyway, over to you.
Thanks, Caroline. Morning, everybody. I'm Fernanda. I'm one of the patient and care experience managers, and I'm here this morning with Carl. Carl's very kindly travelled all the way over from rural East Yorkshire to talk to you this morning about his experiences of accessing services. And I'm going to hand over to Dave, who is very kindly joined to introduce the services that Carl's here to talk about, and then obviously to introduce Carl, who will also introduce himself. Thank you.
Thank you very much.
Good morning, everybody. So I'm David Reed. I'm the Senior Group Work and Volunteer Coordinator for East Riding Partnership, which, as you'll be aware, will be a partnership between the Trust, the Alcohol and Drug Service in NACRO. So within the service I deliver, we're called the Changes Service, and we deliver a 12-week community rehabilitation programme. That is a rolling programme, 5 days a week, Monday to Friday. And that's for people who either do not want residential rehab after detox, or they've reduced to abstinence themselves, or they're unable to because of family commitments, various things like that. So that is part of the service I deliver. We also deliver a family service. So we reach out to the significant others of our patient group and give them support to really help their loved one through their battle and their own crisis as well, because sometimes it's a crisis for that parent or sibling. So yeah, we offer that as support, and we also offer support groups around the local authority using Smart Recovery, which is an alternative to AA. And we deliver them online and face-to-face around the local authority. And within East Riding Partnership as well, we've got our 3 hubs. One's based in Hull, Bridlington and Goole. And we also use satellite clinics such as the Beverley Community Hospital, Hornsey Cottage Hospital, Wivensey Hospital. So we're spread all around the local authority, and within there we have our practitioners, case managers, who receive their referrals initially, which can be done by all professionals using our referral form, or people can self-refer. And then we look at treatment pathways for them, treatment plans, and what really they want, the patient wants, and what motivation they've got as well. So we'll offer harm reduction, needle exchange services. There's obviously a initial assessment, comprehensive assessment. We offer brief interventions at the beginning, and then it's all around solution focused interviewing and motivational interviewing, and we look at what the best options are for the patient, but it's their choice as well. So if they only just want to reduce, then we'd support them in that and how to carry on to cope with that. Or if it's abstinence based, then we would look at the options of detox, or how people can reduce, and then maybe residential rehab or the community rehab. And we'll always offer the group work as well, because that maintains that motivation, and there's the lived and shared experience within the groups as well, which is a vital thing. And that's something else within the service I deliver. I manage the recruitment, training and supervision of volunteers, and Carl, who's here today, is one of our volunteers who volunteers through our Hull hub, but also is at the Beverley Clinic and does quite a lot of one-to-one work with people coming off our community rehab program to support them in their sobriety. So I think I've covered everything there, I think. if that's okay with
Thanks very
everyone.
much, Dave. Thank you. I'm sure you'll get some questions later on. Thank you for
Thank
that
you.
setting.
Hello everyone, my name's Carl, and I've just been asked to come and tell my story, so I'm going to get straight into my story, and it's just my story, so I'll get on with it. It's truly an honour to be here today and to share my story with you. My hope is that by opening up about my past, I can shine a little light for anyone who is still struggling and show that recovery is possible, no matter how far down you go. I grew up in a loving home. My parents worked hard, my siblings had their own paths, and on the outside life looked normal. But even from a young age, I carried something heavy inside me. Nightmares, anxiety, a deep fear of abandonment. Those shadows followed me into adulthood. When my parents moved us to Spain to run a family business, that's when my life really began to unravel. My mental health, which had always been fragile, slipped from manageable to unmanageable. One night, after heavy drinking and drugs, I reached a point where I felt I couldn't go on. I attempted to take my own life. I woke up in a hospital from a coma. My brother had found me and saved my life. I'll never be able to repay that. But instead of finding healing, I turned to alcohol. I thought it would numb the pain. In truth, it only deepened it. Alcohol became my best friend and my worst enemy. I married. I became a father. My daughter is still my proudest achievement, but my drinking consumed me. I lied, I hid bottles, I pretended everything was fine, and while I was slowly destroying myself and hurting the people who loved me most. The years passed in this fog. I worked to provide home for my daughter, but inside I was falling apart. My marriages broke down. My daughter went to live with family because both her mother and I were trapped in alcoholism. Gambling joined alcohol as another addiction. I lied to employers, to doctors, and most of all to myself. I remember lying on my parents' living room floor, shaking with withdrawal, desperate for it all to stop, yet unable to stop drinking. In 2020, my body finally gave in. I went on a binge like no other. Over 8 bottles of wine a day, and my body collapsed. I was rushed into Hull Royal, and I began fitting. I lay there, medicated and terrified. And then something extraordinary happened. A man from Renew came to my bedside and asked me one simple question. Do you want help? For the first time in my life, I said yes. That yes was a turning point. The detox was brutal. The early days of sobriety were dark. Every day I thought, they've taken away my alcohol. How do I live now? But in those hard days, people came into my life who would change it forever. I want to say their names because gratitude is at the heart of my recovery. Belinda, a key worker from the ADS, was the first person who reminded me the world could still be beautiful, even when I couldn't see it. You showed me hope when I hated my life, and I'll never forget you. At Smart Recovery Online, I met Martin Wood from ADS, who completely changed the way I thought about addiction and taught me to challenge my old thinking, and Dave, who followed with the same wisdom and care, helping me to put one foot in front of the other. Next came my friend Ben, a giant of a man. He introduced me to spirituality, to meditation and to gratitude. He taught me how to sit quietly with myself instead of running from myself. That has been one of the greatest gifts of my recovery. And then Lynn, my partner, who I so much to get to, both of us together, we set up a spirituality circle in our own home. The simple circle of sharing and healing gave me community and showed me how powerful compassion can be. Slowly, I began to climb out the darkness. I worked on gratitude every single day. I learned that where alcohol lives, negativity thrives. So I chose light, positivity and service. I started helping others just as people had helped me. And then one day, when I had finished a Smart Circle in Beverley, Martin Wood asked me to mentor. My first reaction was, I can't do that. But my ASL spoke to me, yes, you can, and you will love it. And today I am proud to be a peer mentor with ADS, working alongside incredible people. such as Kirsty, Amy, David and Martin, who I consider now my soul family. Recovery has taught me that healing isn't about perfection, it's about persistence, about the small choices, saying yes to help, attending a meeting, picking up the phone, or choosing to sit with a feeling instead of drowning in a drink. I stand here now, not as a man who was ashamed of his past, but as a man who is grateful for his second chance in life. Addiction tried to break me, nearly killed me, but recovery gave me something stronger than alcohol ever could. Peace, purpose, and a chance to help each other, and a chance to help others. To anyone listening who's struggling, please know this. No matter how dark it feels, no matter how many times you've fallen, there is a way forward. Recovery isn't about reaching perfection. It's about getting back up again and again and again and learning to live with who you are and remembering that your life is worth saving. I am living proof, and I am deeply grateful to my family, my brother, Belinda, Martin, Dave, Ben, all my colleagues at ADS, but most importantly to Lynn, who's my rock, and to everyone else who has walked this road with me. Much gratitude to you. Thank you for listening, and thank you for giving me the chance to tell my story today.
Thank you so much, Carl. Can I just say, I am so pleased to hear that despite everything you've been through, that, you know, there's been a positive outcome. And I say that because actually I'm a child of an alcoholic mother. And so some of what you described, I lived through in my childhood, and sadly lost my mum in 1990. And so much of what you say is connected with my own experience. I do a lot of work with National Association for Children of Alcoholics as well. And I know how tough it is. I do know how tough it is. And so it's really great to hear, not only for you, but for Lynn and your family, that you are, you know, in a place today which you deserve to be, and that we've helped in some way on that journey. So thank you so much for sharing that. Often I think on addictions, you know, we hear about addiction to Class A drugs and so on, and we do work in that space as well. But alcohol is such an important part of the addiction world as well, as you've demonstrated today, and what devastation it can do, but also positively what you can do as well with the right support. So thank you for that today. Can I open it up to colleagues if you have any questions to Carl or to Dave, or even to about the patient care experience work as well that goes on too. Can I see anybody? Right, Lynn. Lynn, and then Steph, and then Stuart.
Thank you. Carl, can you hear me okay?
Yeah.
Yeah, thank you so much for being so brave to share your story with us today. You said it was a privilege for you to be there to talk to us. Actually, it's a privilege to hear you talk about your experiences, Carl. So thank you so much for doing that. You've talked a lot about your experience in terms of peer support, Carl. So that obviously is a big element of the service. But to take that sort of further forward, to improve what we do around supporting peer support, is there anything else you think we could do to take that forwards?
Very good question, and I've wrote just a couple of quick notes this morning. 24% of all adults in the UK consume alcohol above the recommended guidelines. So that's 1 in 4 people with an unhealthy relationship with alcohol. Add trauma or turmoil and just general living conditions now into that equation, and boom, you have a problem. And addiction has the perfect environment to flourish. In my opinion, and this is just my opinion, the place to start is with education and bringing addiction out in the open, and not letting it isolate people, because that's where addiction thrives and wants you to be isolated so it can do its damage. So what I suggest is that we get people talking about addiction, not just the negative stories, because we've all got negative stories. We get people talking about the journeys in recovery and how they are winning the battle of addiction. And in this modern age, social media and podcasts are the way forward. We need to start letting the people know you don't have to sit in silence. There is many other people going through the same experience. So the telling of lived experience stories for those in recovery, because if people know better, they do better. And I am personally, and this is 100% real, I'm fed up of losing brothers and sisters who have died from their addictions. So it's time to start fighting back, and by doing one of the oldest experiences mankind has, storytelling. Storytelling of lived experiences, people from all walks of life coming together and telling their stories of how they are winning the battle with addictions. So I call on the board to help me create a platform where I and other people come together and tell their stories and how they're beating addiction. And through unity and empathy, we could start making a real change.
Carl, that's brilliant, really powerful as well. I think you've set us a bit of a challenge there as well. So I'm sure other colleagues on the board will agree. Let's take up that challenge and do more about supporting people telling their stories for the reasons that you say. Thank you for that. So I think we need to come back to you, Carl, with what we're going to do in response to what you've set out there. Thank you.
Steph.
Thank you, Carl, for your story, and also thanks to you, Fernanda, and also to Dave. Dave, in your report to us, you've set out a comprehensive list of services, and it, just reading through it looks quite complex to me. And what is the glue that holds the whole thing together? How do we help service users and patients guide their way through the plethora of different services and providers that are out there?
Well, personally, I might be biased, but I do think we're probably one of the best treatment services within the country. So we do have a very recovery approach within our staff team. So we do all work together. We promote everything together. So I think that is the glue, the staff team really is, because we all have that one focus of wanting to get people better and to improve their lives and reduce harm to them and their families as well. I don't know if that answers your question.
Yeah,
properly.
thank you. And Carl, how does that feel to you? Do you feel that in terms of guiding your way through the services that we have, that's effective and seamless for you?
I think the services, especially the ADS, do as much as they can with the financing they get. You know what I mean? It's a delicate situation, isn't it? There's only so much money can go into it. But we are losing a bit of a losing battle with more people lapse and relapse. It needs to be taken more serious in this country. You know what I mean? My opinion on it is very contest. Mine's make the breweries pay for it. They're creating the problem. Why is the people picking up? You know what I mean? But I'm not a politician. It's just, it needs more financing in it. It needs to be taken a lot more seriously.
Thank you. Thank you.
Stuart.
Morning, everyone. I'm Stuart. I'm one of the non-executives. And Carl, I want to say thank you on a number of fronts. One is for sharing your story in such an honest and articulate, and you're a brilliant storyteller, by the way. You're a brilliant storyteller. Thank you for that. Secondly, because in these meetings, we discuss a lot of material, which can be a bit dry and impersonal, and you really help bring to life what our services mean to you and others who are recipients of our services. So thank you for exemplifying that. And the third thing I wanted to say was that I was really struck by something that you said. You said healing is about persistence. And I got a lot of sense of resilience on your part. And I think that's a great metaphor for anything one tackles, about persistence. So thank you for reminding me of that importance, and good luck to you, sir.
Thank you very much.
Thank you. Michelle.
Thanks, Carl and David, others. Michelle Moran, I'm the chief exec, and it was a privilege for me to listen to it, actually. And I think Stuart's
summed up a bit about setting the scene for the board meeting, because it's really important that we have that lived experience as we go through the papers, because if not, they do tend to get a little bit dry. And I thought the presentation was just excellent. And a little bit for me has been picked up by the conversation you had with Lynn, and that's how we when we pick up that challenge about reaching out to others, because you're right, it is a growing hidden issue. And I know the addiction service is fantastic, and we've got a really award-winning addiction service, and it does a really great job. It's how we can reach out, I think, further to those folk like yourself, and don't get into that position where you're in hospital, if you know what I mean. So I don't need too much answer to that now. I think we just need to work together, maybe with, obviously, with the addiction service and with the patient experience team. And Dean's put in the chat box, and if you can see it, actually, about, sounds like a podcast series. And I just thought you actually spoke so well that it may be something that we want to explore, really, because it's about breaking down, as you really articulated well, those barriers for people to come forward. So well done, great presentation, and let's see what we can do closer together. But thank you for that. Thank you so much for sharing, and all the best wishes and good luck.
Thank you very much,
Michelle. If I could just maybe a question to Dave and to Carl. Obviously, one of the things I'm interested in is the impact on the family living with this, particularly children. Just to add to a statistic, 1 in 3 children of alcoholics becomes an alcoholic themselves. So there are real issues here about intergenerational addiction. And I just wondered, Dave, what's our approach in terms of our services, or does someone else provide it in terms of the sort of, whilst you're supporting individuals like Carl, where is there the space for the other family members to be heard as well in this? Because it's not always easy when you have a parent who is an alcoholic or addicted, for particularly children to be heard in that, and very conflicting emotions. And again, for Carl, have you felt that whilst you've been going through your journey on recovery, that there was support for your immediate and wider family in supporting you through this, but also them being heard as well?
Well, I'll answer first, Carl. Well, within our service, all family members are made aware of the service, and we will reach out as well, and we talk to our patient group as well, asking that if they feel their family members need support. And then what I should have picked up really when speaking to Stephanie, and I apologise, is we do have that multi-agency approach as well. So if it's not something that we can do, then for a young person whose parent is using substances, then we would refer them into CAMHS or whatever other service is appropriate. And along with that, now with our young people service as well, who we have young people coming into the service, there's something that we provide is called Parenting Under Pressure. It's called PUPS, which is a relatively new for us in the service to be delivering to families as a whole. So we deliver that, and we do have qualified holistic family practitioners within the service as well. So we'll always gauge for assessment what support is needed, and on the feedback that we get from FFTs, because I ensure that I always send them out to family members. I can never guarantee that they reply to them, but that opportunity is there, and we do work closely on the feedback that we get.
Thank you, Dave. And Carl, in terms of your family and support for them?
When it comes to family, I think I've had to deal with my daughter, because she's still going through it now, because I was absent a lot of her childhood, and I was, like I've put in my story, her mum was an alcoholic as well. So my daughter came to live with me, but I was absent. You know what I mean? So I've had to address all her traumas and go through it now. But she's still going through them now. She still isn't quite, as I would say, healed. So we do a lot of work together. But for other people whose parents are like that, like I've already said, I think social media, the kids need to know there's somewhere to go where they can go and talk. Because all this information, like I said, if Renew had come up to me in Hull Royal, I wouldn't have known anything about it. It's sort of shunned or hidden to the side. and people don't want to address addiction, but it's growing and it's flourishing in this country. The more we have a crisis of living, or whatever you want to call it, standard of living problem in this country, it'll go, because people, it's easy to medicate yourself by picking up alcohol. You know what I mean? It's easy to forget and suppress how you're feeling. So I think we need to be more in the eye of the kids. The easiest way is social media, coming forward into a time where people pick up a phone to find out information. They want to know something, and if it's there and they can reach out to it, you know what I mean? Not like Frank used to be, like when he used to read the stories on it needs to be current to children, and they'll reach out to it.
Great. Okay, well, thank you very much. NACOA is actually a service for adults who've grown up, but there's children, they live with alcohol, and there's a helpline for anyone. So you can be a child or an adult to contact that as well. Thank you, Carl, very much. I have visited the addiction services before, but it would be good to catch up, Dave, if you want to get in touch with Laura, my PA at the Trust. And thank you so much, Carl, for today. It's been great having you, and Fernanda as well, being with us too. Thank you very much. I'm sure we all appreciate it as a board. Can we show our appreciation virtually or like that?
Thank you very much.
Thank you.
Have a good day. Have a good day. Take
Bye-bye.
care.
Thank you.
Bye.
Thank you, brilliant. Thank you.
Great. Okay, thank you very much. I think we'd all agree it's just, you know, it's not easy, this. Carl's, you know, it might come across maybe to people watching this that, you know, oh, that's great, that's positive, but I you know, I don't think any of us would underestimate the hard work an individual like Carl has to put in this alongside the services that we provide. That's the big thing that makes a difference. Michelle, Chief Exec's report.
Yeah, good morning, everybody. Thank you for that. And there's a lot in the Chief Executive report. I'll pick out a couple of pieces as usual, and then obviously we can go around the directors. And there are some policies to approve which are on the front cover. And there is also the associate hospital manager to ratify as Kai Turner. Lots of visibility events have been happening. Just little bits of those are contained at the beginning of the director's bit, just to give you a bit of a flavour, but lots and lots happening and getting out and about a lot, visiting our services across the 80 or so bases. That obviously is difficult with the size of the patch. It was great that the gold accreditation for the breastfeeding service, it continues. That's really, it's not easy to get from a UNICEF. Not many areas have got that. So thank you to the team, the teams for that. There is a bit in the paper around the movements of people. I'm not going to go through them. There's been a few changes to chairs and chief execs, and I've actually listed the latest Department of Health and Social Care board that's developed. If you know, they're going to be a joint board. So you just get a bit of a flavour of the movements, and they will continue, I'm sure, over the next few months. It was a shocker and a bit of a disappointment when Claire Murdoch resigned her post as National Director for Mental Health. At the moment, we don't know what is happening with that post. I'm going to be speaking to some people later this week. I just think from an organisation point of view, we need to continue to observe that and influence it to try and get something in relation to that mental health space in the national programme team. So I'll continue to do that as much as I possibly can. The model region was brought up. This, if you remember, we've had the model ICB. So this is a bit of an idea around the architecture of the developing new NHS operating model. And we had the model ICB a few months ago, which set them out to be strategic commissioners and neighbourhood facilitators, leaders, for want of a better description. The model region is it's quite a short document. It's 12 pages and basically puts them into the context of that strategic performance regulator. There will be a chair, which is interesting. We need to see how that plays out with the non-exec capacities across the system. So early days for that, but it has been published. Lots on winter, which I'm sure Lynn will pick up, because that's a really heavy focus. I've been to several meetings in London. The focus is obviously the long-term plan, which we've spoken at length about. Elective recovery, so waiting lists in the acute sector, and winter. It is absent for mental health, I may add. I am strongly pushing that and picking that up, but they're the key things. So Lynn will pick up our plans, and there's been lots of different testing beds in relationship to winter. With that, there's also flu, and the flu vaccination progress will start in earnest in the next week, in the 1st of October. We've already got it in stock. We've got lots of things happening in relationship to peer auditors, peer vaccinators. I'm sure Karen will pick that up. We will have a weekly dashboard. We've got a 5% increase target on last year. And if you remember last year, we were one of the higher performing, if not highest performing in this area from an organisational point of view. And we have stressed the importance to staff. And I know we've got a board session for flu vaccinations in October. So please all be ready for that. The other important thing, which is contained in the paper, which Karen, which just give some headlines on, is the staff survey. We're back in staff survey territory, so there's a lot going to be happening over the next 5 or 6 weeks. Well, the next couple of months, so it's a really busy time as we go into the winter months and the shorter days. But the flu and the staff survey are the two key things that we'll be working through. I'd also ask Lynn, if it's okay, just to give us a couple of headlines on the Langdale fire that happened during the summer in North Yorkshire, because that was a really big, it was a big event for Whitby, and it did affect our hospital and the air quality, and obviously staff live in the area as well. But the staff, as always, did fabulous job at looking after our patients, and we had to alter the air conditioning, etc. But then I'll pick that up. There's a little bit of an update on the NHS regulation for managers, again, which Karen is leading. It's in the paper, and the usual communications and charity appendices, lots happening in both of those areas. The chair mentioned segmentation 2. We had a long conversation at our board away day recently about segmentation 2, but just to remind everybody that we are in segment 2. If you remember, the segmentation scale goes from 1 to 4/5. I'll come to that in a second. And we're a 2, and we're a strong 2. We've got a couple of areas that we need to work through, which is some of our waiting list, which we're already on with, and access in relationship to crisis services, which we already knew about, but we were really working through with the teams. There's a little bit of sickness, but it's mainly those two first areas that we really need to move in to get us into segmentation 1, which is important, because then that allows us to be a little bit less regulated from region and from the ICB, but particularly from region. So it gives us that bit of extra flexibility, which is always important when we want to support our service users and our staff. And that's why we're here. They're key. They're absolutely the heart of everything that we do. So that's positive. It took a lot of hard work to get there. So I thank all staff and my colleagues for that, but we'll continue to work to get into segmentation 1. The segmentation 5 is linked to the provider capability report, which again, you've seen, and we're starting to finish up and conclude in relationship to that. So lots of things happening with the operating model. Lots of things happening within the system. Jason Stamp's being confirmed as chair for the next year on a permanent basis. So we are moving forward, but we'll continue to influence the system, work with the system, but more importantly, look after our business of looking after our patients and our staff that have been at the heart of what we do as we get into the winter months. I'll stop there. That was a bit of an overview. I will pass on to Lynn, if I may, Chair, just to give you a bit of an update on winter. And then Karen, if you don't mind, just give us a quick of headlines on flu and staff survey. Thanks, Chair.
Thanks, Michelle. Lynn?
Yes, thank you. We do have the winter plan on the agenda later as well, so I'll pick up the detail if that's okay when we come to that item. But as Michelle says, there is significant focus nationally, very strong messages that this winter has to be better than last winter. So all of our plans are obviously predicated on achieving that ambition. That's both for obviously the patients and public, but also to reduce the pressures that our staff experience through winter as well. So I think it's good to have both of those messages reflected, that we know that the adverse impact of winter, but as Michelle says, learning from last winter is predicated on what was underlying the pressures, was that increase in prevalence of winter viruses, winter illnesses, hence the significant focus on flu vaccination, particularly. And it's been very interesting to see the national team sort of share that data around winter viruses from from last time. So because we've had that sort of data locally as well, we have taken that into account. So our winter plan we've put together as ever, but particularly with that focus and support from infection prevention and control as well, because it was the reduction in staff availability and the impact on bed closures, particularly in acute hospitals, obviously when isolation measures had to be put in place last winter, that really sort of caused those pressures predominantly. I mean, there were other issues as well, but that was a sort of key learning from last winter. As Michelle says, we have had the unfortunate incident of the Langdale End fire in North Yorkshire. It did affect our services in that there were road closures. So given that our services are predominantly community based, that meant we had to adjust how staff worked through that period to get to our patients and reach them in the same way. So we did that really well. We did have the support of our EPRR team. Obviously, there were EPRR arrangements in North Yorkshire that we participated in on a sort of daily basis through the height of that impact of that fire. So I'm really proud of our staff and how they responded, and we have thanked them as an EMT as well for everything that they did. So there's very limited disruption to our services and we were able to carry on. However, as Michelle's already indicated, it did affect Whitby more than the sort of Scarborough, Moulton end of our services, and there was obviously impact on air quality as well. So we really wanted to manage that, particularly for Whitby Hospital as well. So our estates folks really supported us in maintaining minimising the impact of that, obviously for our patients who are poorly in hospital as well, something we really focused on. So we did have to look at the mechanical ventilation of Whitby and make technical adjustments to that to make sure that we could maintain good air quality. So we are already in the process of debriefing as well, sort of lessons learned from that incident, as we always would any sort of disruption to services. But predominantly really just want to thank our staff for how well they adapted to what was, at least for a good week or more overall, quite difficult circumstances. Just whilst I've got your attention as well, obviously, Steph, you raised the MAPA update. That is in this report as per the work plan as well. So more than happy to pick up any questions in relation to that. There's also a very short section on the EPRR self-assessment process that we're in the midst of at the moment, and I'll be bringing a full report on the outcome of that to the November board. But there's a specific requirement that boards are cited on the KPIs specific to business continuity. So there's a short section in there summarising those and summarising that we are compliant, in our view, through our self-assessment process with those requirements. So again, more than happy to pick up any questions in relation to that. Thanks, Caroline.
Thanks very much, Lynn. And I think the indication we go to Karen now. Karen.
Yeah, good morning, everybody. So following on from Lynn's winter planning update, in terms of our flu campaign this year, so our campaign tagline this year is "Flu Stops With You," and a multitude of communications have gone out into the organisation already in terms of promoting our flu clinics and arrangements for that this year. The flu vaccines are in the building, however, we can't administer them until the 1st of October. So we have a bit of a kick-off event at Inspire on the 2nd of October. But on that day, and for the 2 weeks that follows, we do have centralised hub at the Learning Centre, actually, for anybody to access. And there are booking links available that have been shared very widely in the organisation. Aside from that, what we have done this year is looked at a targeted approach to where we kind of navigate the organisation in terms of where we've got peer vaccinators, but equally where occupational health are going. And what we've used is our data from last year. So the data that tells us where there was maybe a bit of reticence towards uptake last year, so the lowest teams with the lowest uptake, but equally where we saw the highest prevalence of flu-related absence. So our campaign this year will see occupational health roving around the organisation to meet those particular needs. Michelle, myself and Sarah will be at the launch event on the 2nd of October, which is next week, believe it or not. So others are very welcome to attend if you would like to, and I can share the details surrounding that. But as Michelle did mention, we do have a board session on the 29th of October, so we will be coming to you, but equally any of our staff at Trust HQ on that day can access a flu vaccination. I think, again, just picking up on Michelle's wider point, yes, we have been given a target to increase on our own uptake of last year by 5%. So our campaign is really based on driving that up, but ultimately with the view that, you know, having your flu vaccination will, you know, enhance patient safety. It will also ensure that we are all safe as employees of the organisation, and that we can keep flu at bay, and also in the communities and with our families and those that are vulnerable around us. So my plea to everybody is please book your flu vaccination. And equally, if none of those dates fit somebody, you can just go to occupational health and somebody will pop that vaccination in your arm. So thank you.
Yeah, thank you, Karen. I mean, it is concerning across the NHS that get staff, particularly clinical staff, not getting vaccinated in the NHS in England is not where it needs to be. And I think for many of us who get vaccinated, and everyone on this board will get vaccinated, that is concerning. And whilst we are higher than many others, actually our clinical staff, the rates are not as good as they are for non-clinical staff. And I think we would find that concerning, really, because obviously as well we've got patients and contact with both inpatients and outpatients as well. So I'm really pleased, I'm sure we are as a board and the non-executive directors, that there is a targeted approach in this. And I think the message is, you know, if you are particularly a clinical member of staff or dealing face to face with patients and you have concerns about vaccinating yourself, please speak to someone. I think the evidence is actually where that happens, we can allay concerns with people, and hopefully then you will positively agree to a vaccination. But it's such an important, it's one of the greatest inventions ever. Don't listen to someone across the pond on this. Vaccinations are good. I won't get into that. Anyway, right, questions please to anyone who's spoken from the MT, but also for anything else. Gosh, I'm looking, any question? Right, okay, they're coming up now. Thank you. Sorry, Karen, did you want to come back?
Yes, Michelle obviously also made reference to the staff survey, but there is a paper at item 17, so I thought, yes, I won't duplicate, I'll pick it up there.
Perfect. Great. Phil.
Yeah, one of our challenges has been improving workforce retention and recruitment, and with medics, I'm really assured that our training is brilliant. So it's a question for Kwame, which is there's a 10-point plan for looking after resident doctors, bless them. And I just wondered if we'd identified a senior doctor yet to oversee that and how that implementation's going.
Yes, we did. We did get a clarification on the role, and the role should either be the medical director or the HR director. We've had a conversation between myself, Michelle, we've agreed that since I straddle between all the resident doctor, I should do it. So I'll bring something formally to the board. What we've done is that we've done our benchmarking initially, and we are meeting the benchmarking on most areas. There are a few areas where we have gaps, but we have 12 weeks to work through that. So it's important things for the well-being of the junior doctors, and we are happy to contribute to that. Thank you, Phil.
Thank you.
Thank you, Phil. Stuart.
Thanks, Michelle. I always enjoy reading the report, including the progress on health stars and all the stuff that's going on there. So I enjoy that. It's just a placeholder, really. You mentioned in the metrics used to put our position for segment 2. I think you said there's an area of improvement around access to crisis services. when we get to the section in the agenda on the performance report, I just wouldn't mind picking up where we're tracking that specifically in the performance report. We got our eye on it in formal reporting terms.
Yeah, I think it's a really good point. So one of the things that we have said at the exec team is that we probably just need to have a quick refresh of the performance report. We've put some of the national data in there already, but just have a quick review and just make sure that we are tracking it. We are, but that we're keeping a closer eye on the things that we need to do now for the segmentation. But I'll bring Pete in, because obviously Pete's the custodian of the performance report and the segmentation. He just got his hand up, so that's okay. So that's great. That's a good
Certainly,
point.
thanks.
Yeah, I was just going to step in, Michelle, and say we have drafted, you know, and it is drafted at the moment, it has been to exec a couple of times, a performance specific report just on the oversight segmentation metrics. That will ultimately come to board, Stuart. It's going through its testing phase at the moment, and then we'll have sight of it here in the board. It'll be a separate appendix to the performance report like we do with the long-term plan metrics.
Yeah, and obvious thing is that if we're worried about something, we want to measure it, let's put it on the performance report so it's all in one place. Yeah,
absolutely.
Yeah.
Thank you.
And I think we're refreshing it, because what we don't want to do is it to get too big, Stuart. It needs to
Yeah.
be focused. So that's what we're doing. Because if you remember when we did it in April, we took some things off because we no longer needed to do that.
Aye.
So we're just looking at it in the round, but absolutely, it will be there.
Thank you.
Okay, thanks very much. There are quite a few things in the chief exec's report from other executive directors that might come up later on the agenda. So, you know, there'll be another opportunity to do that on the performance report and maybe other items as well. Phil?
Yeah, apologies, I'd written another question there, but I've got to
It's
ask
all right,
it.
you can have more than one.
It's about Health Stars. I noticed that the operating costs seem to outweigh the grant costs, and I just wondered if we are working hard to maybe remedy that, in that actually maybe we should be making more grants, more wishes.
Good point. I'll pass over to Pete, who leads Health Stars and what have you, Pete?
Yeah, I'll have to just pull to that page, Philip. My understanding this year, the income target's 200,000 for Health Stars, and the operating costs are about 75 from memory, without having the page in front of me. So our income target this year outweighs the operating cost of the charity, and then our target next year increases further to 300,000. So it's 3 times the operating cost, if that makes sense.
Yes, but I'm more in the income's important, but it's also how much we distribute in wishes.
I think what you're saying is should we be not using more of that money for the wishes rather than just having it stocked up? So I think it's made really good progress in relationship to
Yes,
our
I'm
income
aware of that, yes.
and our operating costs. Because obviously we do monitor that, but I think what you're saying is should we spend it quicker? Pete?
Don't disagree, Michelle, but I guess we can only spend what people wish for. You know, and we've done a lot of work, haven't we, with fund zone managers, encouraging people to submit wishes. We've streamlined the wish process. It's an online form that processes quickly. It's a work in progress, I think, you know, and I do mean this generally. I think there's a lot more confidence in the charity now than there was maybe 18 months ago, where wishes were submitted and they were kind of going into the ether and never getting progressed. You know, and I guess the big spend will come through the dream campaigns. You know, so obviously the ones that we've got live at the moment, you know, Molten is a big dream campaign for us at the moment. I think we've raised 15,000 of the 50 fundraising target so far, and obviously that will start to see that spend probably the beginning of next year.
No, thanks, Pete. That's helpful. Just want that reassurance that there were plans to spend. Yeah.
I mean, it has been I would say a quite dramatic transformation in terms of the wishes, both in terms of contact with, you know, colleagues across the organisation, making wishes in response to them and getting back to them, but also the process of guiding people about when they put wishes as well. But as you said, Pete, there's also the other, if you like, the dreams as well, which are often of a bigger order in terms of the money needed and the fundraising that needs to be kept going to make sure that happens. Michelle?
Yes, I was going to say it's a really good point for when anybody visits, to encourage staff to use the charity. I know you probably do, but just to have it on your in that file. Obviously, we mentioned staff survey, we mentioned vaccinations, etc. Just to publicise Health Stars as well, because you're right. Even though we do spread the message, it's still not fully out there, and we need to look at how we can continue to do that. But it's really good when we go out just to suggest that as well. So I know that you will do, but just to refresh and just to remind you. Thanks, Chair.
Pete?
I think it was just to say almost exactly the same as Michelle. We do bring wishes up when we go on our visits. You know, I know myself and Sarah were talking about the courtyard garden at Aspire, which is one of our dreams, and myself and Karen were chatting with the matron at Millview about how we can, you know, use the charity to support the garden works there. So we're actively pushing it, you know, and I'm just hoping we start to get more and more traction and people start to see, you know, why did that happen there? And it's because we put a wish in.
That's very, yeah. Thanks, Pete. Thank you. I can't see any other hands indicating a question, I think. So thank you, everybody. There will be other items on the agenda where we might explore some of the points raised in the Chief Exec's report as well. So thank you very much for that. We will move publications and highlights. Oh, sorry, let's ratify. So I'm going to go through this. We have Kai Turner, Associated Hospital Manager appointment. Everyone happy to ratify that? Thank you very much. I'll just go through each of these. Seclusion and segregation policy, happy to ratify. Yes, thank you. Bullying and harassment policy. Yeah. Any concerns? Right, okay, thank you. Flexible working policy, happy to ratify. Brilliant. Attendance management policy. Yeah. And finally, physical restraint policy. Brilliant. Thank you very much. Publication highlights report, Michelle.
Yeah, thank you. Again, I won't go into this if you've had a chance to read it. There's been a lot on, there continues to be a lot of national reports coming through. There's a little bit of a snippet underneath, as always, in relationship to what we're doing, but open to questions.
Thanks very much. Really helpful report, especially the sort of Humber view on it as well, just below a summary of that. Any questions? Plenty of reading for you to go away and have a look at. Brilliant. Okay, thank you very much. So we move on to our patient safety and quality section of the board, and we have our colleagues from the patient and care experience team with their annual report. And we've got Mandy here, I think. And Kwame, did you want to say anything before we go into the video?
Yeah, no, just to welcome colleagues here. Hard work has gone into it, and Mandy and Felicity are here. So please, can you start?
Okay,
welcome, Mandy. Mandy, I know we're going to go straight into the video, I think, aren't we? So yes, I'll hand over to you to introduce that.
Lovely, thank you very much. I just want to introduce Flick, who is on the Humber Talent Programme. Flick has been shadowing me through the annual report approval process. So, hi, Flick.
Welcome, Flick.
James, if you would be kind enough to share the film, please. This shows the Patient and Carer Experience Annual Report 2024-25. Yes, thank you.
Pleasure to present to you. My pleasure to present to you our Patient and Carer Experience Annual Report, including complaints and feedback for 2024-25. The Trust is committed to actively engaging, involving, hearing, listening to and acting upon feedback. And we hope this report demonstrates the significant strides we are making to involve everyone so we can provide the best outcomes possible for our patients, service users, their carers and families.
As Medical Director for the Trust, I oversee the Patient and Carer Experience agenda. I would like to introduce you to the Patient and Carer Experience team, who would highlight what we have been doing over the past year.
There is an intrinsic link between staff satisfaction and the direct impact on patients and the standard of care they receive. The Trust's 2024 staff survey ranks our Trust as the top trust to work for in the region, sharing a very positive picture of staff experience, which directly enhances patient care and satisfaction.
Our experts by experience are people with experience of using services as either a patient, service user or a carer, and once registered on our expert by experience database, are paid for undertaking activities within the Trust. During the past 12 months, 32 individuals have been involved in Trust projects and initiatives where they have been paid for their contribution.
Patients, service users and carers continue to provide feedback by participating in a number of surveys including Friends and Family Test, Community Mental Health Service User Survey and the National GP Survey. Feedback is shared with staff and where learning is required, action plans are produced to make improvements.
The Trust has started working on the Patient and Carer Race Equality Framework, which all providers of NHS mental health services must use to support their organisations to commit to and embed anti-racist values throughout the organisation. This is needed because national and international data show that both access to mental health services and the treatment people will receive can vary by ethnicity.
At Humber Teaching NHS Foundation Trust, you put me at the heart of everything you do. Thank you. I am proud to be a service user carer governor amongst several other voluntary roles within the Trust. I really do feel that my voice is listened to and heard.
As Healthwatch managers, we work in partnership with the Trust to ensure the voices of our communities are heard.
Our close working relationship helps to ensure that you are understood, to influence and shape the services that the Trust delivers.
October saw the launch of the Children's and Adults Learning Disability Services Connect website, which hosts 28 children's and learning disability services in one platform. It offers easy access to important information and features animations co-produced by service users and the individual services.
We're excited to celebrate the second year of our Humber NHS Cadet Programme in partnership with St John's Ambulance Service. This initiative offers young people a tailored opportunity to explore careers within the NHS. This year, 22 young cadets, many from diverse local backgrounds, will graduate the programme.
This year, the Learning Disability team worked alongside 5 registered experts by experience over 3 different projects, including the Culture of Care project at Town and Court, the Cancer Screening project with Bridlington Primary Care Network, and educating students at Hull University about family therapy.
Being able to be paid to share my experience and connect with professionals is amazing. I feel like I am really helping make a difference to the services I have been a part of.
Staff and volunteers have curated a collection of artwork displayed throughout Whitby Hospital, showcasing its rich history. These pieces offer patients and staff a unique opportunity to explore and learn about the hospital's heritage and the surrounding area's fascinating past. On the back of the 2024 National GP Survey, the Trust's 3 surgeries have introduced a new telephone system and an online booking and consultation system. All actions from the survey are developed with the practice's patient participation groups.
A patient is leading a project to raise awareness and improve the resources and information available, particularly for inpatient services, about the 9 protected characteristics supporting equality, diversity and inclusion. A work experience initiative has supported several inpatient service users working in the on-site shop. This has led to a further project looking at volunteer roles for inpatient service users in the forensic division. Staff and patients will be training together to gain the Level 2 food hygiene qualification. This will enable both groups to share good practice and support the preparation and cooking of food together on the inpatient wards once achieved.
A carers card has been designed to connect carers and families to support available within our communities. By having a business-sized card including relevant information to hand when needed will encourage more individuals to access support services. De-escalation, management and intervention training has been enhanced by the introduction of lived experience films to make it more meaningful.
Being an expert by experience has had a positive impact on my life and mental health recovery. Feeling confident to openly share my experience of mental ill health has felt empowering and motivates me to stay well to continue to contribute.
This year, the Trust responded to 502 complaints, 188 formal complaints and 314 informal complaints. This is a decrease of 52 complaints compared to the previous year. Communications and patient care are the top primary subjects. The Trust implements actions from complaints which are upheld and partly upheld to improve our services. Of the 188 formal complaints responded to, 43, 23% were upheld, 70, 37% were partly upheld, and 75, 40% were not upheld. For the previous year, the Trust responded to 198 formal complaints, of which 60, 30% were upheld, 56, 28% were partly upheld, and 82, 42% were not upheld. 47 of the Trust's 133 clinical teams, 35%, have not received any formal or informal complaints in the last 12 months. This remains the same percentage as the previous year. The Trust received 432 compliments this year from patients, service users and carers, which is an increase of 129 on the previous year. The Complaints and Feedback team offer training to ensure our staff understand the complaints process and are equipped to manage complaints and concerns as they arise. Over the past 12 months, 229 staff accessed this training.
May we take this opportunity to thank each and every one of you for your continued support on this very important agenda. Your involvement is key to ensuring you are at the heart of everything we do.
Great.
Thank you.
Great. I'm jealous about not having an avatar myself. I mean, seeing all these faces. Kwame, you seem to have missed out there, but actually I think it's a really effective way to do it, actually, in terms of, obviously we like to see people in real life, but I think it's really effective. And can I just mention something? Marilyn Foster, who colleagues will have seen, she's one of our governors, but also obviously involved as a volunteer as well. She had a lovely avatar, I have to say. I recognised Marilyn straight away. I just wanted to feed back that at Market Wheaton Health Practice over the summer, an event was organised with our support to encourage people to come in from the community, and apparently over 200 people came on the day. And Marilyn, when I was catching up with her on this, did want to mention that Phil Anastasi, who you saw with a bit of a 5 o'clock shadow going on there, I thought, in his cartoon version, was absolutely amazing in helping make sure that that was a successful event. So please pass that back, Mandy, to him as well. But I think that it was very informative. Mandy, did you want to go straight to question? Because everyone, we've seen the video and we've had the report. Yes. I think you wanted to just go to questions and comments, I think. Yes?
Yeah, that would be great. Thank you.
Okay. So let me see. Hang on. Questions and comments from members of the board on any of that or what you've read already in the report? Stuart.
Hi, Mandy, nice to see you again. Really very detailed report, love the video, love the report. I really like the kind of you said we did analysis under each section. I want to just pick up the issue of communications, which comes out quite prominently in the complaints, both in the complaints raised and the complaints upheld. So sort of almost on parity with patient care complaints.
Yes.
And if I've understood it correctly, some of the sort of root causes there in the complaints, although those issues are to do with lack of contact from or to the service. And I just wondered to what extent we've really got a handle on the root cause of why people are complaining about communications, because it can be language, it can be, the accessibility, it can be the channels, but it sounds like there's an issue of responsiveness somewhere. Have I got that right?
Yes, yeah, and it's been for years, communications has been our top theme it is something obviously that we're very aware of, and regionally every organisation has the same issue. To the point that we are involved with an initiative that the King's Fund originated. Our ICB are leading on this initiative called A Good Experience, and it's all about a communications charter. And the communications charter is being developed with in partnership with York St John University as well. It's taken quite a while, because as you can imagine, there are a lot of patients in the ICB area, but we really do want to get to the bottom of it. And we've held a number of workshops in our organisation, as well as organisations outside of our trust, to try and understand and get to the bottom of it. And it is so varied. I can't say it's a specific communications theme. It, you know, it relates to digital technology. There is, of course, English second language. It is about that two-way process when you're on a waiting list, and that communication between the patient and the staff. There's so many different, different themes that it's very difficult to pinpoint one particular theme, Stuart. And I think quite a lot of those communication complaints, both informal and formal, over the last year relate to primary care as well.
Right.
And relate to obviously accessing a GP, getting through on the telephone, same with the crisis service, which I know, there's a lot of work going on in the background to address, trust-wide as well as for the individual complaints as well.
Yeah, so I don't underestimate, it's not unusual for communication to come up in any kind of survey, whether it's internal or whatever. So it sounds like you've got a sort of a variegated problem. You've got a handle on some of the root causes.
Yes.
It's clearly very complex. It's not a new thing.
No.
And you're working on it in collaboration with others. So thank you.
Yes.
Yeah,
Okay.
good luck with that.
Thank you.
Steph.
Hi, Mandy. Thanks so much for the report and for the video, both of which were extremely accessible. So thank you. I've got a couple of questions in two different areas. The first one is around Healthwatch, which is obviously to be no longer, sadly. And have we identified any areas that are currently looked at by Healthwatch where we think we need to be doing something as a trust, perhaps to replace some of that work that they have been doing, which is excellent work around the whole health economy? And the second area is around the PACE forums, which are a super way of engaging across different health organisations with the voluntary sector and other partners, and also with some individual patients and patient groups as well. Do we have any strategy for the coming year around increasing involvement of patients and partners in the physical meetings that we do, and looking to expand maybe some virtual ways of reaching people as well?
Okay, thank you, Steph. Good questions. So regarding Healthwatch, our organisation, the Patient and Care Experience team and all 4 divisions meet with Healthwatch every 6 weeks. We meet with the Hull and the East Riding Healthwatch managers, and we also bring our complaints and feedback manager into those meetings as well, so that we can keep a handle on the concerns that are being raised through intelligence reports that we receive every month from the organisations. Again, similar conversation that I've had with Stuart, we don't have specific themes. We do have generic themes coming from Healthwatch. Over the past couple of months, there's been no concerns relating to our organisation for August and July's Healthwatch reports, which I share with the divisions when they arrive. Neurodiversity is an issue, and that led our complaints manager to having regular routine meetings with our Hull Healthwatch manager, so they can continue to be in contact to ensure that both parties are sharing the types of complaints that are coming in, the types of concerns that are being raised, so that they can both work together. And that to me is the is probably the largest concern that has come in over the past few months. Last year we had issues with our Humber Primary Care GP practice, and a lot of concerns coming in there. But in all honesty, a lot of work has been done, and now we've totally turned that around. So that was another area of concern. But again, we worked very closely with Healthwatch East Riding and we developed an action plan on the back of both the Healthwatch report that came in and also our annual GP survey results. And it's a massive improvement has been seen on the back of all that work over the last 12 months. Second question regarding the patient and care experience forums. We are aware that it's a bit hit and miss with the forums as to how many people are physically in the room. We have our 3 patient and care experience forums, one in Whitby and District, which twice a year we are face-to-face and once a year we're virtual, usually in the winter months because of the geographical area up in North Yorkshire. So we do tend to do one virtually, and that was an agreement that we made with the patients, carers and service users that attend that forum. Hull and East Riding, we have a lot of patient service user carer groups as well as our patient and carer experience forum. So what we've found over the past few years is we've got a bit of a diluted audience now, because people who would have attended our patient and care experience forum are now, for example, attending the mental health service user co-production group. We've got younger people between the ages of 15 and 24, where few of those would have attended our forum, but they now attend the Humber Youth Action Group. So although our numbers don't look huge, they're always around between 15 and 30. Once upon a time, they would have been a lot higher before all of our additional user groups came into effect. So Scarborough and Rydale Patient and Care Experience Forum, we host that forum jointly with York and Scarborough Teaching Hospitals, because we're obviously on the same geographical patch and they don't have any forums. We weren't getting many patients to that forum. We were getting a lot of staff, but not many patients. So we buddied up with York and Scarborough, and that really has increased our membership. Now, we do get a number of members from community groups who then feed back to their patient groups, but we've always held those then face-to-face. So November's forum we're hosting virtually to see if that makes a difference, because again of that great big geographical patch in North Yorkshire. Also, my team met with our communications team just yesterday to look at a marketing campaign for our forums to try and increase the strategic, as I call them, patient and care experience forums that we're talking about today. And we've got a plan in place with posters, TV screens, social media marketing, staff global communications, and also when my team go to the divisional meetings to update them on a quarterly basis on the work going on in patient and carer experience, we're going to have a big focus on asking divisions to remind staff about our patient and care experience forums and the posters for their patients. But what we don't want to do is take away from the operational patient and care experience groups that I've already mentioned, like the Humber Youth Action Group and for example, in forensic services, they've got their patient voice group as well. So there's a lot of additional groups out there where we're collecting feedback and enabling people to get involved in trust activities. Does that answer your question and give you some more reassurance?
Yeah, thanks, Mandy. That's brilliant. Yeah, really looking forward to seeing how that develops over the next few months. Thank you.
Thank you.
Yeah, it would be interesting to look at a baseline, Mandy, of where we are now in terms of those different geographical areas and regular attenders, to see where we can, if you're going to have the campaign, what the outcomes would be. That would be really quite helpful, I think. Phil.
Yeah, just to inform board that this report and the next 2 reports have also been through Quality Committee. Yeah. I think my fellow non-execs have asked questions that were raised, particularly around PACE forum attendance. That was raised at the Quality Committee. Mandy, just one thing that is just a plea moving forward, which is as we start more digital interfaces with the patients, and make sure that perhaps we don't repeat the initial error that was made generally with primary care is that once we got an online total triage tool, that was seen by patients as a barrier rather than increasing access. And moving forward, primary care, the requirement is that, for example, that there's equal opportunity of access if it's in person, by the telephone and online, so that if we could just check from patient and carer experience that any digital tools, interface tools that we employ actually improve that experience of communication, because I think it's going to be a big deal, and how it's implemented and how it's played out to our patients and carers and families is really important to how it's perceived, because it definitely in primary care, not just our primary care, but primary care wider, when they were first implemented, they were seen as a barrier to stop people attending the reception desk or on the telephone.
I think that's a really good point. We can assume that we're doing a really great thing to widen access. People might, as you say, Phil, see it as a message, we don't want you coming in person. And I think that's reflected actually in some of the national polling of patient experience and what they're thinking at the moment about these changes. I mean, as an organisation that has lots of psychologists working for it, behavioural psychology is a really interesting part of this, about how people respond to communications. And maybe as part of this project you referred to, Mandy, hopefully that's embedded in it. We might assume people will respond in a certain positive way, but they take a negative rather than a positive from some of this stuff, which feels, I think, explained well. Okay. I can't see anybody else. As you said, it has been through the Quality Committee, and I think I attended that one as well. So thank you very much, Mandy, and to the team. Lots of good work happening, and I think hopefully those comments are helpful.
Thank you very much. Thank you.
Thanks, Mandy.
Nice
and Flick, hope you're enjoying your shadowing and get a lot from it.
Thank you.
Brilliant. You're welcome. Have a good week. Okay, let's move on there. Oh, we have to actually ratify that document. Is everyone happy with that? Great, lovely. Infection Prevention and Control Annual Report. Sarah, this is for approval.
Thank you, Chair. So yeah, looking to approve the Infection Prevention and Control Annual Report. Difficult slot to follow after the great video that was shared around the patient and carer annual report. As Phil's already alluded to as chair of the Quality Committee, the two subsequent reports have been sort of through Quality Committee. I think key highlights to draw to the board's attention this morning is that it is a positive report and demonstrates how we're fulfilling our statutory duties in relationship to infection prevention and control. Our outbreaks are minimal as an organisation, and myself and Lynn have fingers crossed going into the winter this year that we will continue with that vein moving forward. We have a really positive compliance in relationship to our training and our hand hygiene. What you'll see across both the next annual reports is really how we're trying to embrace that PSIRF, so that patient safety incident response framework, as part of our wider patient safety agenda. So that's whether that's infection prevention and control, or whether that's the safeguarding agenda as well. And hopefully you can see that thread through those annual reports. I've just noted in there sort of a couple of risks in relationship to water safety, but that's something that we ongoingly sort of manage through the use of sort of filters and through our estates programme, which also sort of Pete is really cited on, and we ensure that as part of any new builds and redesign that we kind of factor in that sort of ventilation and water safety aspects as well. Those were the key things that I was going to highlight. But happy to take any questions. Thank you.
Thanks very much, Sarah. Are there any questions, particularly from those who weren't at the Quality Committee that had a good old look at this? Stuart.
Yeah, thanks very much, Sarah. I just wanted to pick up that point about the capital programme, and just want to check with Pete the process for dealing with the various calls on the capital programme and how infection prevention control features in the consideration of what's invested in. How do you deal with that?
Well, there's two parts to it for me, Stuart. So in the capital programme, we ring fence
sum of money for compliance works, which will come and feed through the ventilation, the asbestos, the water safety group. So any remedial works where we've had adverse readings would come out of that allocation. And any new design scheme, we use our authorising engineers and we consult with infection control and all the other groups in terms of the relevant points to be fed into the design of a new build or a major scheme.
Great, thank you.
Happy with that, Stuart? Great, thank you. Okay, thank you very much. Sarah, can we approve that report, please? Happy to do that. Thank you very much. Move on then to the safeguarding annual report. Sarah, you're back up.
Thank you. Again, another sort of really positive report in relationship to fulfilling our statutory duties from a safeguarding perspective. I think one of the challenges that we have had over the last 12 months has been our compliance, particularly with our level 3 sort of safeguarding training. Our overall training for safeguarding is always above trajectory, but in relationship to that level 3, that more in-depth complex training, we've had a bit of an improvement piece of work going on over the last sort of few months. And what you can see within the report as of request from the Quality Committee was just that updated level 3 compliance, which you can see on the sort of front sheet. So we're up to where we need to be from a level 3 safeguarding children perspective, and just need to get the adults just over the line, currently on 83.2, so just need to get it over that 85%. So we will continue to monitor that quite closely through EMT, but obviously through Quality Committee as well. We continue to have a really good working relationship with our local authorities in relationship to those partnership agreements, and you can see from the data within there that we have good reporting in relationship to safeguarding as well. Always participating in any of the statutory reviews, and again that echoing that comment around how we're really embracing that PSERF methodology as well as part of that wider patient safety work as well. But again, looking for approval and are happy to take any questions or comments. Thank you.
Thank you very much, Sarah. And again, this has been through a number of different forums before it's come here as well. Any questions from colleagues? No, thank you very much. Can we approve that document, please? Safeguarding annual report. Thank you very much indeed. We move on to the annual self-assessment for placement providers, Karen and Kwame.
Kwame's coming in on this one, Caroline.
Oh, sorry, I've got your initials on these.
It's both of us. It's both of us.
Right. Okay, fine. Okay.
Thank
fine.
you. So
Kwame.
we've been working together on this. So this is a mandatory quality assurance process for all organizations in the NHS who deliver NHS-funded clinical placement. And the self-assessment is we benchmark ourselves against the NHS quality framework, and it covers areas such as learning support, supervision, governance, and workforce sustainability. We are very proud that a lot of the information that we put into this document suggests that we are delivering against those standards. Not only is it to provide assurance to the NHS England, but also to enable us as a trust to reflect on current practices, identify strengths, and there are a lot of strengths that we've identified. There are some areas that need improvement, but there are very few. We continue to do continuous improvement and learning. And this document outlines the current position, key findings, and it is for board consideration. I'm hoping that board members have read the report, and if there's any questions, we will take them.
No, thank you very much. That was great. Just one thing. I think you have our colleague Phil Earnshaw in there, and it might be quite good to give him his doctor title in front of his name, just so that we've got someone on the NED team who has a bit of knowledge in this space as well. That would be quite good. That was the only thing I saw when I went through it. Very comprehensive. Hope everybody agrees. Great. Any questions? Brilliant. Okay, can we then approve the annual self-assessment? Thank you very much indeed. And Have we got Alison with us today, Michelle? Yes, there she is. Hi, Alison.
Morning, Caroline. Good morning, everybody.
And we'll move on to the Freedom to Speak Up Guardians annual report, please.
Thank you. Do you want me to start, Michelle, or did you want to introduce? Yeah, okay, thank you. So, yeah, really pleased to present the Freedom to Speak Up Annual Guardians Report for 24-25. This has been through the People and D Committee. Just wanted to pick out a couple of highlights, really, in terms of our sort of the priorities that we're following as part of our strategy. So in terms of training for Speak Up, there are 3 levels of training through the National Guardians Office, and level 1 is mandatory for all staff to complete. We'd set a target of 85%, and I'm pleased to see that we've exceeded that. So 96.02% have taken up the training. We do have a little way to go on level 2 and 3, which came out a bit later. Level 2 is for managers and level 3 is for senior managers. So as part of our plans for this year, we're continuing to push an increase in that, and we're seeing that already. During 24-25, there were 31 concerns raised through the Guardian and through the Speak Up processes. This is against a position of 39 the previous year, but when we look at this against all of the trusts of our similar size and similar makeup, we're not a particular outlier. Some of the trusts don't submit their information to the National Guardians Office. We always do on a quarterly basis, which gives us a good opportunity to be able to benchmark against those others. You'll see the types of concerns within the report, nothing particularly of any difference to the previous year, but also what we've included this year is some of the outcomes and how by staff raising concerns we've been able to deal with these, but also particularly change some of our systems and processes, particularly in the clinical areas. We've continued to strengthen our oversight with our operational teams, HR and quality and safeguarding. So I think that's been a particular focus for this year. And you'll also see the positive feedback that we've received from staff through the anonymous questionnaire that we seek. So there's some nice testimonies there where people have felt confident in using the Speak Up processes. Really pleased to say that we've had an internal audit during that year, which received significant assurance. And we've also now completed all of the recommendations, which were specific, quite minor, really. You'll see in there our plans for 25-26, which we're well on the way with. One of the particular areas is to increase the number of ambassadors. We're getting quite a lot of those now, and we're actually starting to see people talking to the ambassadors and cases coming up through the Speak Up processes. So I'm happy to take any questions and ask for the report to be ratified. Thank you.
Thank you very much, Alison. Really good to see those outcomes, things that people have raised translated into some really positive changes. And I think on behalf of the board, thanks to you, the Deputy Speak Up Guardian and the ambassadors involved in this as well, and the time you put in. We all appreciate it very much. Any questions to Alison or comments? Stuart?
Yeah, Alison, thanks for very, very quick question, very clear report. In the table on the analysis of staff groups reporting concerns,
yeah,
the line qualified nurses, kind of, you look at the trend, it went from 6 a few years ago to 10 to 16 and back to 6. Are you reading anything into that, positive or negative?
No, I think the other thing to note is where we might get a concern, it could be more than one person raises it within a particular group. So if we've had an area where there's been a concern that's been raised by a number of staff, that might be one of the reasons. And just thinking about that around last year, that particular area where there is quite a number of qualified staff. So no, nothing to particularly read from that.
Mm-hmm.
All right, thanks.
Yeah, and just to reflect back to colleagues, Michelle, Dean and myself meet quarterly with Alison, and one of the things we look at, Stuart, is when we go through some of these and who's raising it, and we also look at if there is the location of the service, and whether there's multiple voices raising it and what have you. And we look at also what happens over time on that front. So we have a good conversations about those issues. I feel, I hope Michelle and Dean would agree with me, to look for patterns and trends and all of that as well. So I hope that provides a bit more assurance on that front too.
Yeah, thanks.
Okay, Michelle.
Yeah, I was just going to say that actually, that I think it's very robust, and obviously, as Alison said, we've been audited about that, and I think it's very good that we get that non-exec scrutiny. To be honest, at those meetings, it's an appreciative challenge, but I think it's really positive to have that independent and oversight. The other thing, just to reiterate, Stuart, is we want to increase the numbers reporting, because that's the honest, open culture. So I always think it's positive that actually the numbers have gone up, because it depends on what they are, obviously, and the gravitas of them. But we want to reach out, which is why we're increasing the ambassadors that we've got, increasing coverage, and both from a freedom to speak up and a complaints point of view. I always look at where we're not getting many or we're not getting any at all, because is there more an issue there with people not feeling that they can, etc. So I always look at it in a way, we need to handle it, we need to sort it out, but that at least people are coming forward. So I do think that's interesting.
It's why I raised the question, because the number had gone down, and it's always like in any, the more you know, the more you understand.
Indeed, and that, I'm just reiterating that. So if it goes down, then we do have a look at it. The only thing that we spoke about it at length was the staff survey, because the staff survey said that they knew how to access it. But I think by increasing, that's why we're trying to increase the ambassadors, so we can really make sure we've got that reach into the services. It's a really good qualification, and we always look at it. I'm just trying to give you a bit more reassurance to it that we are aware of it. Is that helpful?
It is.
Alison?
Yeah, I was just going to pick up on that, because obviously this report is done at a point in time, and it's the previous financial year. We're already at we're nearly at the end of September, and we've seen an increase in the number of people contacting. So we're at about 21 concerns. So there is that increase, and obviously, as Michelle said, the staff survey has shown an improvement as well on those two specific questions. But what some of the work of the ambassadors is actually drilling down into the divisional responses to those two questions. So yes, we might have shown an increase, but some areas might not have done, and that's where we're targeting our efforts really, in terms of communication and getting that visibility.
Great, thank you very much.
Thanks.
Thank you. Thanks, Alison. Right, is board happy to ratify the Freedom to Speak Up Guardians annual report? Brilliant. Okay, thank you very much. Thank you very much, Alison.
Thank you, Caroline. Thanks, everyone.
You're welcome. Thank you. Let's take a break. It's 11:06. Let's come back at 15:15 and we'll resume. Okay, thanks, everyone. Thank you. Welcome back, everybody. We'll get back onto the agenda for our board meeting in September, and it's item number 14. And over to you, Kwame.
Thank you, Chair. So this is, again, a very important statutory duty of a designated body, which HAMBA is, and also responsible officer duty. And those of you who've been around for a bit longer will remember very bad Dr. Cole Shipman. Since then, doctors have to go through a rigorous appraisal process and revalidation process. And every year, this document is to send to the NHS England as well as GMC to assure them that we are meeting our statutory duty in terms of revalidation appraisals for doctors. So the documents are clearly outlined, shines light on our governance processes, our quality improvement. This ultimately is to help protect patients, ensure that the doctors are supported and also held to a good standard. So there are a lot of good areas that we worked through this year as well. And part of moving forward is also to make sure that our processes are even further enhanced by doing a peer review with another trust who will come and look at our process and also look at their processes. There are other areas which we look at some of the agency doctors who move from organization to organization. We're making sure that our checklist is extremely robust so that they don't fall through the net. We've talked about the speakers' freedom to speak forums. We got a GMC last year to come and talk to us about our process to make sure it's robust. And all the monitoring systems that we've had has been very, very positive, and it's also again shown in the report. So if there is any questions, I would be happy to answer. Thank you very much.
Thank you. It's a comprehensive report. I've been through it. Any questions or clarification needed from any colleagues? No?
Philip, happy with that. He's been through that process many times.
Your expert eye on this, Phil?
No, it's really reassuring and assuring. Everything's as it should be. There doesn't give me any cause concern whatsoever, which is brilliant to be able to see.
Okay. And I think it's a really positive to be partnering with another trust for some external work as well. And I'm really glad to see that in this report too. I think that's always beneficial for our learning and for their learning as well, for that matter. But yeah, thank you. So that's for assurance. Everybody happy? Thank you very much indeed, Kwame. I think, have we got Karen? Is John with us today?
No, you've got me, Caroline.
That's fine. Over to you, Karen, for the EDS 22, 2025.
Yes, so you've got the EDS 22, or the Equality Delivery System, with you today for approval. And this is a mandatory requirement for all NHS providers and commissioners to complete each year. So you will have seen a previous iteration of this before. What this provides us with is a collaborative overview of our progress across the EDI agenda related to patients and the workforce as well. So I thank Mandy and her team, as well as John and the workforce team, for their collaborative efforts pulling all of this together. I think given that we've seen many of the EDI annual reports, particularly in the July board, actually what this does is gives us assurance that actually we're making solid and sound progress, and we're reporting that now into NHS England, and that's been acknowledged. So in terms of the highlight points, we are achieving in a number of the areas, and we're scoring 29, which is up from 25 last year. And I think, and again, what is apparent from the other reports that you saw at the last formal board, actually the areas that are of focus for the organisation, as I've discussed before, are around bullying and harassment, and we are enhancing the visibility of our Respect and No Excuse for Abuse campaigns in order to tackle that particularly. But I will leave that there, and I'll just open for any questions.
I've got a couple of questions. Anybody else got any questions or comments? Stuart?
Yeah, thank you. I've got, well, one observation I think I made earlier this year, that we do have a lot of initiatives, don't we, and programs in the EDI space, and it looks like this particular template is the culmination report of all of those things together. To what extent are we marking our own homework here? So I can see reference to sort of an external validator. Are we marking ourselves fairly here, Karen?
Yes, I would say so. In the sense that, do you believe that we're down marking ourselves, so that we maybe need to, aim a bit higher, Stuart?
No, I'm just want to understand I guess the process by which we arrive at the figure, and is there an external input into it? And I can see Dean's putting in the report that this has been to people committee already, so maybe I'm double asking the questions. I just want to understand the veracity of the analysis, as it were.
Yeah, so it's an internal analysis, but it goes through a number of parties. So it has also been to the quality committee, and I know that it did get a huge scope of conversation within the quality committee, and then was picked up again in the people committee.
Yeah.
So like I say, whilst these are it's an internal analysis of our progress, it does align to the other reports that we have submitted to the board as well in terms of what we've achieved.
Okay.
Anybody else before I ask my question?
I was
Dean.
just going to say,
Dean.
It's a really good question, Stuart, and we do look at this report alongside, as Karen was just saying, really, the workforce race equality standard and the disability equality standard, and this year it also came at the time of the annual report that we do on equality and diversity that went to both people and committee. So we do get that triangulation in that way. But there's a lot in this area, isn't it, that's about inputs of doing things to make things incrementally better,
yes,
rather than the transformational sorts of change things. So what we're looking at, I suppose, is that year-on-year progress and hoping to push further.
Thank you.
Thank you, Dean. I sort of had a similar sort of observation to Stuart. I mean, I appreciate basically what you've just said, Dean. We have a number of different reports in different guises in this space. And it's just that sort of sense of seeing the wood for the trees, I suppose. And I suppose in this report is just thinking there's a lot of stuff happening here, but there were two things for me, was about, well, what are the outcomes for the things we've done? So, for example, I think there was a pilot put in there in terms of dentistry services in forensic, and that was an input. It would have been really interesting to know, well, what then was the take up of patients to use that service? Have we improved on that since the previous year or something like that? Now, again, we have a lot of reports in this space, but it's sort of just how can we, gather the information, and I don't know whether it's in this one, to, if not on the template, in an executive summary. And again, I think I would have liked to see an executive summary, Karen, that in some ways explain that. And then the other point was on from achieving activity to excelling activity. It does have in the report a points-based system for deciding whether it is achieving or excelling. I suppose, again, I sort of thought, well, what would it take us in some of those achieving to get to excelling? And again, I don't think that would be covered by the template, because presumably that's an NHS one that they've designed, but maybe we could take it on ourselves to reflect that in an executive summary about where we might need to go. And that could be something that could be, I'm sure, might have been discussed at the People's and Organisation Committee, Dean, that then could have been reflected in the executive summary that took place, and there's a sort of sense of that. But again, it's the outcome side of thing, and knowing what we need to do to get to excelling in some of these areas that I thought was, could be focused on somewhat more, and as well as the front sheet and executive summary, maybe be able to go in a little bit more information about that. I hope that's helpful.
Yeah, no, I think that is a really helpful observation, Caroline. Obviously, we've worked within the constraints of a national report, but actually for next year, absolutely, we will develop an executive summary to cover that off. I guess the other thing that I would say in terms of sources of assurance, and particularly outcomes, so obviously with a focus on the areas of focus, particularly from workforce around bullying, harassment, disadvantage of those with protected characteristics, we rely on a number of data sources that we present then through the people committee and into EMT, such as the staff survey. We know that we saw a significant improvement for the question around reporting bullying and harassment behaviours, staff to staff and patient behaviours as well. So that would, to me, certainly indicate that we are doing the right things, and that those assurances are provided through other reports. But particularly the patient things, you make a point about the dentistry services. I'll pick that up with Mandy. I don't know if Kwame can come back on that one particularly about where that maybe fits from a patient PACE perspective.
Yeah, I mean, I think that's just an example that I just could recall from sort of reading it, but it's that sort of, we've done the activity, here's the input. What difference is it made, if you see what I mean?
Yeah.
That I think that's and that's not, obviously we talk about that in other areas of our services as well. But I thought it's probably there, the information. It would be good to know it.
Yeah.
Thank you, Chair. Yes, obviously now we've implemented the EPR and a number of technologies that link into the EPR. It's coming back to the board to give an update on where we are on that optimisation. Paper has been prepared on what classes rather than benefits the lead key performance indicators are systems being used. Is there activity in the system, and where we are now achieving a level of financial or non-financial benefits. The report breaks that down between a number of systems. The Yorkshire Care Record, which has seen a significant increase since we moved on to System 1 because it's a contextual, basically the report in your press, and the system launches against the patient record. So it's just made it so much easier to access information concerning that patient with other organisations compared to what we previously had. AccuRx, which is around patient communications. So the default is to communicate with the patient digitally, unless there's some accessibility or requirement on the reasonable adjustment that's required. We also use that for the consent, because we can communicate with all our patients around how they want their sharing to be set up within the system as well. So we used it for major campaigns. Also useful for questionnaires to receive information into System 1 directly. It's quite a well-known system in primary care. It is being used a little bit in secondary care. Lexicom is voice recognition, and we are now expanding that into ambient scribe. So there's a small early implementation starting on the ambient scribe, which is not taking account of the benefits, but it's just for awareness. EPR extension is just showing it is being used. Actually has very good feedback on usability, better than our new EPR from usability, but it's very good at doing one particular job, which is looking at historic data. Again, that is linked directly back into System 1, and also Bridget from a handheld device point of view. Overall, there's a general improvement, and we are now seeing a reduction in the cost of postage and also in prescriptions. Oh yeah, I missed the electronic prescription service. We're now live with all our services on electronic prescription services, which is really the transfer of the electronic prescription from the electronic prescribing and medicine management system we're already using to pharmacy, which has some financial benefits but major patient benefits as well. Because again, patients are just receiving their prescriptions at the pharmacy of their choice rather than having to come and collect a paper one or us delivering it. So again, quite a good from our patient perspective and saves us cash. There's still a piece of work too on that one to get rid of the paper written FP10s, and Miriam and Kwame are working on that piece to reduce it to an absolute minimum where possible. There could be some exceptions based on extenuating circumstances, especially for it could bring external staff in that had to cover work, etc. But the principle is to go electronic. Overall, positive on the experience, on the performance. The one negative is the Bridget handheld, which is in community, physical community. So basically Scarborough, Whitby, Malton, etc., where we're working with the service to increase, or at least to be really clear on what is the benchmark for measuring success of the handheld devices being used rather than laptops. So, there's a general feedback from staff that give me a handheld that I can record contacts, care plans, etc. It'll make life a lot easier. That capability is there. We started in community when we was doing the EPR migration for mental health. It's had a few challenges. We're now getting over them challenges. It's now getting that embedded and getting the usage in to show the benefits. So, I mean, that's a bit of a summary. Overall, it's positive. So really, papers there. Any questions?
Okay, thanks very much, Lee. Questions from colleagues? Phil? Oh, yes, Phil's first. Yeah, and then Pete, then Stuart.
Lee, really, really great to see it. I'm really glad that we've got EPS going. In general practice, it transformed your life. You couldn't believe that what you used to, what you do, and the safety and the sort of audit tools it gives you is amazing. My big question really is, this is all great, but what's next? What's our ambitious plans for next for digital?
So so on the next plans, I mean, there's two bits. We really need to embed rigorously on processes on this, Phil, and we're just going to be careful that we don't start chasing the shiny stuff without getting the basics embedded, or at least the enhancements embedded. Where we're looking for is around the use of AI technology. So there's two aspects of it at this point, and software as a medical device. So we've got the Do-It profile of software as a medical device, which we are working with the neurodiversity children's services, should really make access and support significantly better than it is at the moment and deal with some of our real pressure points. There's the use of ambient scribe. I know there's quite a lot going on that at the moment. We've already got 500 lexicon licenses that we'll be pushing out on the ambient scribe. The reason we're doing the lead doctors is to really check we've got the right devices so it works effectively and it reduces burden on patients, but also we get that direct integration with System 1. The other one is using the AI tools in Databricks. Now we've got the data layer sorted, so we can start using AI in the algorithmics and start using that for some of the linking health inequalities to accessibilities to other other things so we can start being far more focused on where we provide care or where we might need to reconfigure our services so it's more effective. There is a link around research as well, Philip, around the SDE and data feeds that we're also exploring at the moment. That was progressing quite well, but it's just been paused because the North East and Cumbria and Yorkshire Number SDEs are both just merging at the moment. So we just need to have a clear understanding of what's the direction of travel before we build for the data feeds for the on system. So I mean, that's just a few of them. There are other things. So, the other one I've missed, which is the Wayfinder, Philip. So it's connecting directly into the NHS app Wayfinder, which historically on mental health and community has been fairly lacking, but doing it directly into the NHS app rather than having to go through some middleware. It does require some enhancements on the NHS app. There is a version 2 that they're working on because the feedback is generally quite funky, but we can get the data feeds going. As a trust, we're leading on behalf of a collaborative of 35 of the System 1 practices on that piece of work, Philip. So that one looks pretty exciting because it'd be great to actually get that true integration with the NHS app and patients. So there's a few things there. And so go. Sorry, I went.
No, good.
Thank you.
That was a lot.
There was a lot. Probably another report for a couple of months, for a quarter's time or something.
Yeah,
I would guess.
I think we need an in-depth managed discussion on some of those exciting developments that are happening. Thanks, Lee. Pete, and then Stuart.
Thanks, Caroline. Just wanted to thank Lee for the report. It's great to see the dashboard. I know a lot of work's gone into it, Lee. And from the board's point of view for assurance, we see these dashboards at the Be Digital Group, which feeds into EMT, and will probably form part of the productivity section of the next Finance Committee, which will start to include as we onboard more and more technology, Chair.
Thanks very much, Pete. Stuart.
Sorry, Caroline.
Yeah, I'll let you come back in a second, Lee. Hang on, let me get Stuart in there.
Well, it follows on. Thanks for that. Yeah, Pete, you mentioned the point about productivity. So it's really interesting in terms of productivity analysis. On the lexicon thing, which is really, I find that really fascinating. It counts millions of words being said. Is there any kind of like quality assessment of what's come out? Because people speak in a way that's very, very different to the way they write. And we had a previous conversation about communication between the trust and service users, and I wondered if there's any quality assessment of the the stuff that's coming out of people's mouths that's then converting to text, right?
So there's been a level of independent reviewing of what's gone in there. We've used some of the research AI tools from HIMSS to check, and it's at least an equivalent quality to what would have gone in, but it's taken a third of the time from a practitioner point of view. The only issue is voice recognition works for some people, it doesn't work for others. I see that very different to the AI scribe, which really should be a big burden reduction, which is, I think that is going to be our real opportunity for productivity. So we have done, I could probably dig the research. I don't think we did it as a formal report, we did it as a quick bit of research with HIMSS on the information we had. So yeah, it was at least as good on what went in there. But that was post the clinician reviewing what had gone into the system as well, Stuart. So it wasn't just raw, because raw, you do need to check it and you do need to validate it, otherwise we are in medical device territory.
Yeah, wow, brilliant. And another reminder of how rapidly the world is changing through technology, right?
Yes.
Thank you.
Okay, thank you very much. Michelle and then Kwame, and I've got a question. Michelle.
No, thanks all. Thanks for the questions from the board, and obviously thank Lee and others, because it's a really obviously important agenda, and I'm really pleased to see the board taking so much interest in the digital agenda, because obviously I think it's one of those that are really going to help us when we look at our transformation. And as you know, we're linking our productivity, because it's a very dry word, isn't it? We need to make sure that we're producing services that are more effective and efficient and better for patients. So that's why we're linking it with our transformation work and our QI program. And I think really one of the key things through that is digital. So I think it's really great that we've now got the dashboard, because it's asking a lot more questions of us, and we're picking those up at the exec management team, and we'll continue to do that and bring those back through the various committees. But it's also interesting and good that the board having that digital day with NHS providers as well. So I think it's that rounded nature, because, you know, the use of AI is important, but we need to, as you rightly said, Stuart, make sure we use it in the right way. And it's that language type of thing. We can have all these pieces of kit, but if they don't do what we need them to do, or they're not making services better with better outcomes, then we need to make sure we review that and go on to something that is. So I think it's that whole transformation piece that's important for the exec team and me. So really good to hear this conversation today. So thank you for that, and great to see the work that's happening behind the scenes as well. And well done on the optimisation, or the continued optimisation of the EPR, because I know I'm speaking to staff, Lynn, I know you've put in the chat box, but it has got them engaged in the digital piece, which is something that we never thought may happen, but so that's really good.
Yeah.
Thank you, Michelle. Kwame.
No, thanks, Lee. This is it's clearly we are moving from the analog into digital, and this is all examples of the fact that we are completely into a digital world. And I think that some of the data that you are producing is really, really good. We are able to see the quantitative data, but I get what Stuart was asking in terms of the qualitative aspect of it. And for example, EPS as an example, the patient safety conversation is so important, irrespective of what money we save. And hopefully as we develop, we might be able to underpin that. Michelle said that we might be able to underpin that with quality improvement activities, which we can demonstrate clearly that, for example, patient safety in terms of medication error has reduced by 50% since we introduced EPS. So those are some of the things that we are talking about in the clinical oversight group, to try and bring clinicians to support the digital team and work hand in hand to make sure we can also not only show the qualitative angle, but also the quantitative angle as well. Thank you.
Thank you, Kwame. If there's nobody else, I've just got a couple of comments and questions. I mean, I think this is it's a developing area, and it's a good start. And I was really pleased to see some specific numbers in terms of money saved and a number of SMS messages sent. I suppose, and this sort of links to Stuart and an earlier discussion we had about communications, that we might think something is working for patients, but we're not sure. So there's a couple of things really. So we may have, you know, a lot of our patients receiving text messages. What can we do to make sure that when they get those text messages, it's resulting in that they are turning up for appointments, for example? So it reduces the number of did not attends. Do they find the text messages helpful? I mean, you know, do they give them what they need? And I'm just thinking about what your team, what's the interface with the PACE team on maybe doing sampling and whatever to check that experience. And I think in some of the other areas, I mean, it says about reduce the administrative burden on clinicians. When we're at the start of these, digital innovations, how we are setting a baseline, for example, the amount of time a clinician might use using the old analog way, if you like, in terms of moving to the digital way. Because if we don't have that baseline, and you may have it, Lee, I'm just looking for assurance here, really, and evidence, is if their baseline was spending X number of hours doing a certain activity, are we actually got our baseline, but also going forward, and this is for other digital obviously transformation as well, are we actually then being able to see whether this is really making a difference? I mean, there'll be anecdotal, but we need to sort of see what that is, and I think that would help as well. And so in some of those areas, I just think there's just let's at the start of these things really be assured that we're getting the right measurements in place with baselines to be able to really provide clear assurance that this is making a difference. Because otherwise, it can end up like, they've got so many words they're using. I mean, what does brilliant look like? I mean, if they're doing, I don't know, 250,000 words on it, is that good for an organisation of our side, or out of all the other words that are being done? It's 400 clinicians using EPR a month or whatever it was. Good. I'm sure it is good. You've mentioned it, but is that the optimum where we want to be? So I think there's some things there. And there was just a little thing on the risks, which it says that the use of the new systems, there's a small risk that it will not improve productivity or create saving to meet the trust financial plan. Maybe it would be helpful, and not today, but I sort of feel I'd like a bit more assurance on that one, about what the small risk is. But I think some of the other stuff around baselines and outcomes and knowing what good looks like and potential savings will give us I think as a board a better sense of assurance on some of this, I think, and good practice for other developments we're going to be doing in this digital space. I hope that's a reasonable request.
That's fine. If I can just come back on the how do we know about are we improving or not? So we're working so the digital cash and non-cash release savings. We're working with the finance team on from a patient level costing, service level costing. So it's a direct link into how we're being measured, how we're showing productivity and performance from the point of view of the digital component. So it's not being lost. It is completely with the with that particular team that's where the information is coming from on the finance side. So it is very clearly linked. On the risk side, the small risk is really linked to if any of the indicators. So potentially, let's look at it. Bridget as the handheld. If that really fails, the question is, would you pay for it? Is it adding value? So the indicators, the lead indicators for the KPIs ahead of benefit are the way of managing them particular risks and issues. There's some other data quality of benefits because there's additional support and training that's required for certain teams to make sure we get the best out of the EPR. I think the issue with, and that's so for all the Monday.com performance stuff, including DNA, because we do track the DNA data with the DNA group as well. That's on Monday.com. That's shared between quite a large number of people, that real-time dashboard or near real-time dashboard for all the KPI progress and the benefits as the benefits start being released. So that's why it's a small risk rather than a big risk.
Okay, I think what I probably, I appreciate that, and that's really helpful. I think what I probably want in a report to board, something which would give me a reassurance that on any new digital adventure we're entering into, that there is a constant look at weighing up the cost against productivity outcomes. Obviously patient experience I think is about that, and then if there is a particular risk in a certain area about whether it's actually worth doing handheld as opposed to people using iPads or whatever, that could be just identified as something as a work in progress that is actively being looked at. Does that you know what I mean? Reading that in this is sort of sounded a bit sort of, I think it didn't represent what you've just said in some ways, and I think that just tweaking that a bit for the report would be really helpful going forward. Is that okay, Lee?
Yes, that's absolutely fine. Yeah.
Perfect, lovely. Hope I haven't opened Pandora's box there, but thank you for that. Thank you for that open discussion. Okay, is everybody happy with the assurance provided today? Yeah, great. Thanks very much, Lee. Thank you.
Yeah, thank you, everybody. Bye.
Great. Moving on then to National Staff Survey, which you mentioned earlier, Karen.
Yes, thank you. So just very quick update in terms of where we are with the launch of the 2025 staff survey, which will land in predominantly in boxes, but some paper copies to some staff on Monday, the 6th of October, and it will be open until Friday, the 28th of November. We have ambitions to drive up not only the engagement of it, but also to see that year-on-year improvement in terms of staff experience compared to last year. So the paper sets out our communication plan in terms of how we plan to incentivise the staff survey this year to encourage uptake, but there is that leadership responsibility and accountability as well that we have been discussing particularly with our ODG and our wider leadership community this year. So this plan has been to the executive management team, and it was discussed at a joint EMT-ODG timeout as well only a few weeks ago. What we have decided to do as an executive team is increase the incentive this year. So we will be offering a weekly £75 prize draw. And also at the end of the campaign, there will be an iPad and an iPhone up for grabs, as well as kind of team treats and encouragement along the way. There also will be a league table this year, so teams will be able to see where they are positioning compared to their peers in the organisation. But as you know, the staff survey is one tool in which we understand understand staff experience in the organisation, but also feedback. And we are very clear that staff have a number of mechanisms in which they can feedback throughout the year. So we are always very clear about that, but this is a really key recruitment, retention, engagement tool, but equally it does sit within the new oversight framework as well. So it's really important that we do get staff behind engaging with the staff survey. This year, a couple of things that we are really focusing on as part of our communication campaign is around dispelling some of those myths, particularly around the anonymous nature of the survey, which it is. Our staff are each given a unique identifier, and IQVIA are the administrator of the survey. So when there are the awarding of prizes and incentives, it actually comes from the centre at IQVIA. We're trying to tackle that neutral response position. We know that sometimes people might feel that they don't have a view either way. So we're really trying to open up the dialogue around what that means when somebody puts a neutral response, because actually if their experience is good and they put a neutral response, sometimes that can lend itself to sitting within a more negative category as part of outcomes. And also that great message that we have about what a wonderful trust Humber is to work for comparably. And we've talked extensively before about the reward and recognition and the benefits and the employee value proposition we have at this trust. So again, our communications really will be focusing on, ensuring our staff are aware that actually we've got a lot to offer. That said, we do take the staff survey very, very seriously in terms of what we can do with it. And we've seen that manifest particularly around some of the areas of focus around the EDI agenda particularly. So I'll leave it there and I will just open up for any questions.
Thank you, Karen. Any questions to Karen on that work? It feels like you've no sooner done one staff survey and it's back again.
Absolutely.
Okay, anything from anybody? Okay, great. I mean, we've done a tremendous amount of work in the last 2 years, Karen, and everybody involved in this trust, and also all our staff who respond. Thank you so much, because actually, that's the most important element of all of this, isn't it? Continuing that good practice and good work is really important, as well as learning from each year. So thanks for that. Okay, we can move on then to the finance report. Pete, please.
Thanks, Caroline. So reports there, I'll take it as read, but just pull a few bits out if I can. So if we start with the system financial position, so folk will remember that for Humber and North Yorkshire, we submitted a break-even plan as part of the financial reset back in April, and that position was dependent on just short of 80 million deficit support funding. At the end of July, so we only have the month 4 data at system level, across Humber and North Yorkshire, we were recording a 20 million year-to-date deficit position, which was roughly 5.5 million adverse to plan. Currently, if we look at a straight line forecast on that run rate, we're heading towards a 60 million pressure across the system, and work is continuing with some of the acute providers, particularly in terms of recovery plans to get a level of confidence in terms of delivering the break-even position for the year. Obviously, one of the worries is deficit support funding, because that now has to be earned, and we have to provide assurance to the regional NHSE team that we are on track to deliver our break-even position, and they have to have a level of confidence. Linked to that, cash is increasingly becoming a concern, and I'm picking up concerns of cash support potentially being needed towards the end of the financial year. And I guess that concern becomes even more so if the deficit support funding is not earned. So I think it's fair to say the system is looking challenging at the moment, but I think we've seen that before in the board. For the trust, we remain 3 million ahead of plan at the end of month 5, and that was purely to do with the timing of some non-recurrent income with the ICB. We continue to remain confident we're going to deliver our break-even plan by the end of the year. We have some risks to manage, particularly we've got some pressures in the mental health division, and we are working through that for our accountability review process. And we have a bit of a pay award pressure that we're still working with our commissioners on. But our confidence to deliver our plan remains high. So I'll take the rest of the report as read, and I'm happy to move to any questions.
Thank you very much, Pete. Any questions, comments, observations from colleagues? Very clear, I think. Phil.
Could you just say just a little bit more, Peter, about what the issues are in the mental health division and against budget?
Yeah, so there's probably 2 areas within that division that we're running a little bit hot on, Phil. One is our inpatient units. Our staff costs in our inpatient units are running above our funded establishment, and we'll see in the performance report, we know sickness is an area of focus within each of those units, and we're doing some targeted intervention work. And the other area where we're experiencing pressures is probably out of area, where we have a huge focus in out of area. It tends to go up and down a little bit, and we even picked it up at ENT on Tuesday, didn't we, Lynn, where we've actually got plans to repatriate again. So those are the 2 areas that are running hot, and then we're working with the division on a financial recovery plan.
Thank you.
Thank you very much for that response, Pete. And question, Phil. I can't see any other hands up, so can we note that report, please? Thank you very much. Let's move on to the performance report, Pete.
Lovely, thank you, Chair. So this is our performance report as at the end of August. Generally, our performance is presenting a similar picture to what we reported previously in the board, but to pick out just a few areas again, we continue to see strong performance in our workforce metrics. Training is really high. Our vacancy position is strong, and our clinical supervision remains above target. Operationally, our early intervention in psychosis and care programme approach performance is also strong. And we're continuing to work through the recording of care contacts in terms of some of our access targets through the EPR optimisation group. And we're starting to see that evident in the figures now, which is really reassuring. This month we did see a decline in our talking therapist performance, and some of that was due to capacity in the team and a rise in demand. But the division have been looking at how we can maximise the subcontracted activity where appropriate, and there has been some focus on managing staff absence, and we have got some recruitment to that team that's coming online in the next month or so. So a bit of a whistle-stop tour on performance. I don't know if any of my exec colleagues want to pull any of their areas out, or if we move straight to questions, Chair.
Any other executive directors want to add anything before we open up to questions and comment? No, okay. Just to say on the front sheet, there is a typo in that there are 14 units flagging red for sickness. It says 14 in the other parts of the document, but there's just a typo on the front sheet there that needs correcting and bringing to people's attention. Any questions?
Just to say, well spotted, Caroline.
Thank you very much. It was a test, wasn't it, Pete?
It wasn't, I assure you.
Phil.
Yeah, no, thanks. Obviously, we've got 1 or 2 key issues around waiting times, and we've rehearsed those issues quite a bit. It was good to see that early intervention psychosis seen people in 14 days that hit 100%. So that's great to see. Increasingly, NHS is sort of measuring mental health trust on how many people we get through the system, which has been a bit of a surprise to me. But for us, there's some evidence that activity levels are dropping off in things like perinatal, children's, young people, and all contacts, actually. I just wondered, is that represented in a drop in our waiting lists, or is it... what is anything behind it, or is it very variable depending on service? But I just thought I'd ask a question about activity levels, since the NHS centrally seems to be scrutinising us on that.
Who wants to respond to that?
I think Lynn's put her hand up, so I'm
Lynn,
assuming
sorry,
Lynn's
sorry, Lynn.
Yeah.
Lynn.
Yeah, perinatal's a very good example, Phil, as well. So we don't have excess waiting times at all for perinatal service. So it's an access target responding to prevalence as well. So we have the capacity, and we do a lot around raising the profile of this service as well. So it's not that waiting times are negatively impacting that access at all. In fact, we have that capacity available to actually see more service users. So it's really around, how we make sure that people know about the service, which we absolutely do, that obviously our maternity services, and we have liaison obviously with those services in place as well. So I'm happy to chair the partnership board for the perinatal service. So constantly looking at what more we can do to raise the profile, for example. So I think it's a very good question. So I hope that answers your question.
No, it's obviously with that particular one, that's us behaving in a way that's very unusual for the NHS, which is raising profile and saying, come and use us. Yeah.
Okay, thank you. Stuart?
Sorry about that. Yeah, just a quick comment on the on those waiting times graphs that we've been tracking for a while. It's on page 391. The 52, for example, the 52 waiting list there. If you look at the right hand end of the graph there, I'm hoping we might be just seeing some kind of plateauing going on. I'm not asking anyone to comment on the forecast, but it'd be good to keep our eye on that, to see if we've finally seen the last of the rise in that graph there. And then the second thing, just to reiterate my earlier comment, the segment 2 metric, we're going to make sure that we're including something in this performance report to cover that segment 2 metric on access to crisis care, I think. That was it, thanks.
Thank you. Stuart, any response to what Stuart's just highlighted?
I'll just come back in on the over 52-week position, Stuart, with the exception of children's neurodiversity. I hope I've been indicating at the board for some while, we continue to have significant focus on improvement plans in place. We did suffer from some data quality issues in this picture as well. Similarly, we've been working really hard to eradicate those. I think we absolutely are, she says cautiously, at the tail end of seeing the data quality due to the new EPR system, but along with making sure that we do eradicate the overfit. So each service where they exist, bar neuro, has a definite plan to eradicate over 52 weeks, but actually to achieve the 18-week standard as well, which is obviously where we want to be, where we've got the commission capacity to achieve that. So like you, I think there is reasons to be a bit optimistic. The reason why I hesitate is we're just about to go into winter, of course, and whilst we're well planned for that, that obviously potentially could have a adverse impact. But I think we've done everything we can over recent months to be in a good position to manage any sort of surge in demand that we might see through the period.
Yeah, thank you.
Thanks, Stuart. Thanks, Lynn. Steph?
Yeah, just a quick question on the Safer Staffing report. Do we actually do friends and family tests for community services? Just a quick question.
Sarah?
Yeah, we do offer FFT within community and primary care.
Okay, it's just not coming through on
particular...
it's not coming through on the report.
The community section of the Safer Staffing, Steph, is actually having a bit of an update because there's a number of community services that aren't captured within that. So through sort of QPAS and Quality Committee, that dashboard does need a little bit of a refresh. So that's one of the areas that is on my radar as well. But thank you for pointing that out. Thank you.
All right, thank you. Cheers.
Thanks very much. Okay, I can't see any. I've got with the questions or comments. I've got a couple just following on what from Steph said, and just bearing in mind that we had the PACE annual report. There's, from what I read, there were 3 areas in red for friends and family surveys. I presume work's being done to look at what's going on in that space with those particular areas. Also, I mean, look, there's lots of good stuff actually in this report, just to say, you know, but some of the areas where we are exceeding our targets in terms of where we are, I think we've asked this before, is do we need you know, in terms of reviewing those targets, do we need a stretch target in some of those areas? Because we tend to sort of every month it's really high and it's really good. You know, what, you know, I'm not saying it should be, but is there discussion around that? And the other thing I just, you know, going through it as well, just we have a mix of percentages and numbers. And others may not feel this, but I sometimes feel actually having a number would be quite helpful against some of the percentages. And I'd just be, you know, appreciate just having a look at that to aid our understanding, because, you know, a percentage, if you don't know what it's a percentage of, if you know what I mean, it doesn't give you necessarily as clear a picture. And the only other thing was about just in terms of, I think there were some issues around talking therapies and vacancies creating a problem. I think I've read somewhere else actually that we've filled one of those areas. So that's good to hear, but maybe a little comment on that. And just on the waiting times, the over 52 weeks. I mean, obviously in the report, we have the data on 6 weeks, 18 weeks, and then there's 52 weeks. Again, that sense of, you know, between 18 weeks and say 52, what's the shape of things looking like in terms of people maybe waiting 30 weeks or 40 weeks or what have you. Do you know what I mean? To give a context to this. And the other thing just on that, and you may have answered it earlier and I missed it, so apologies for that. Into some of some of the indicators around the trajectories that, you know, again, whether it's it's gone beyond peak and it's sort of stabilizing, which is good to see. It's just about, obviously, in terms of keeping ahead or keeping up, it's a number of referrals coming in. So even if we take people, particularly the children and young people, off the 52, it's about the flow isn't into it. And we had a really interesting bit of discussion, didn't we, Michelle, about that at our board away day the other week, about what's the flow happening, because it's almost, you know, it's like dealing with the flow in. If we can do something more about that, then it's going to decrease the numbers that we have actually just on the waiting list as well, where that is appropriate, as I would hasten to add as well. We're not stopping anybody being referred. It's about what's appropriate. So yes, some observations in those areas, Lynn.
Yeah, really key ones. So just on how we manage that sort of whole picture around waiting times and the data, Caroline. So if there is a service with an over 52-week wait position, we break the data down, as you would expect us to, into what that means at 18 weeks, what that means at 30, 38 weeks, right up to the 52-week position. Because obviously what we know is if we don't manage that whole position, then people will tip into the higher waits. So we almost sort of, you know, person mark those patients, as it were, through that process. So so in the action plans that you'll see to reduce the waiting times, it doesn't just focus on over 52-week waits, because that wouldn't address the whole pathway process issues. It really does look, predominantly we're looking at below 18 weeks. Some services, specifically Talking Therapies you picked out, has a specific target around 6 weeks and 18 weeks. So where that's necessary and applicable, obviously we look at it in that effect. So we have a waiting time capacity manager actually who works with the divisions, who's come from an acute background, who's really got that expertise around sort of elective waiting times, etc. So, and obviously we do apply that capacity and demand process all of the time and repeatedly, that looks at every point in that sort of clinical pathway for those particular service users in whichever area we happen to be focused on. So constantly looking at what we can do to improve that position. I think it goes back to the productivity efficiency conversation we've been having through board today. How do we use the enabling technologies as well, and the new digital technologies to support process right through those pathways as well? So I can assure you we're not just looking, obviously we constantly look at the demand picture as well. We know what the referral demand is at any given moment in time, so we're constantly looking at the SPC charts around that. What does that tell us around sort of what patterns are we sort of seeing in those particular services? So where we are able, obviously, to signpost service users to more appropriate services that actually that referral isn't sort of meant for us, needs to go elsewhere, then again, obviously we have those sort of triage systems in place. So it constantly is looking at the whole process, not just the endpoints. And as you quite rightly say, if we can manage the inflow in the most effective and productive way, then obviously that will mean that we will manage that through our pathways. And obviously we want that RTT, the referral time to treatment time, to be as short as possible, because obviously that is the most efficient and effective way for everybody to access that care and treatment before people's needs become more complicated and complex. And I think, unfortunately, that was sort of one of the impacts of COVID, wasn't it? That we didn't see people early enough. People weren't coming to services in the same way. So I think we've learned a lot from that experience as well in terms of how we apply those improvements. But I think it goes back to the points that Michelle was raising earlier around service transformation. To how do we make sure that those patient flows, you know, are optimized through our services, using all the available resources, including technology, to support that. And that absolutely connects to that productivity efficiency agenda as well. So sorry, I feel like I've rambled on a bit there, but I hope I've given you the key points to the areas that you've raised, which are really important.
And can perhaps go away and have a look at whether adding the actual numbers alongside some percentages, and likewise when there's whether that might actually be helpful on some of this space. Yeah, that would, I appreciate that. Okay, great. All right then, thank you very much. We move on then to the Trust Winter Plan. Lynn.
Yes, thank you, Caroline. So obviously we've touched on this already today. So this is our plan here today for your approval. The plan itself, as usual, has been predicated on the national requirements. We talked about those earlier. Strong expectation that this coming winter is significantly better than last winter. So NHS England produced an urgent and emergency care plan in June this year. Whilst that was a broad plan, it was very much focused on winter. They followed that up with some key lines of inquiries to support ICBs and all organisations to produce the effective plans that they wanted to see in line with what they'd published in that document in June as well. So our plan has been predicated on both that NHSE document and the CLOEs that subsequently were published too. This year is the first time that boards are being asked as well to approve an assurance statement in relation to the winter plan. So that's in the appendix to the paper that you've received as well. So I guess in terms of, we've touched on it already, one of the key areas that we are asked to respond to this year is improved vaccination rates. We've already talked about that. There is an expectation that we achieve at least a 5% improvement on the uptake of the vaccination from last year. And there is a focus, as we've already talked about, on frontline staff. That's where the focus is expected to be seen, because uptake, whilst ours was good overall last year, but nationally the uptake of frontline staff wasn't where we would, I think, all want it to be. Obviously, there are other key points covered there in terms of the increase in the number of patients receiving care in primary care and community settings, and specifically, obviously, where mental health service users present, in mental health services, not in EDs, particularly or to the acute hospitals. The expectation that a maximum 45-minute ambulance handover time, which obviously was problematic last year, is achieved. So there's been no sort of improvement overall in the UEC measures, no change from last year, but just the expectation that the measures are actually met through this winter, this time. So obviously improving flow of patients, obviously patients waiting over 24 or 12 hours rather in ED. That there are local targets, particularly around discharge as well. So our plan continues to focus around discharge. So you can see for yourself sort of what the key ask is, sorry, from the national team in relation to measures. There's been a more rigorous approach as well this year in terms of testing plans. So there's been various approaches locally for us. We've tested our plan through a workshop internally. We've engaged in ICB-led events around testing as well. And this year, NHSC led a programme of testing at regional level as well. So we participated in that too. As I was explaining earlier, there's been a significant focus, as Sarah said as well, on IPC preparedness for this winter because of that lesson learned from last winter about prevalence of winter viruses, staff availability. So the CLOEs cover all of those areas around staff and preparedness as well. Reducing sickness absence overall very much is connected to the plan as well. We had our own sort of lessons learned process that we followed in terms of our plan from last year. So that learning has been taken into account as well. So I'll stop there. More than happy to answer any questions. But what I'm asking the board for today is to approve the plan itself and then to approve the assurance statement that's attached to the paper.
Thank you very much, Lynn. Any questions or comments? Michelle?
Yeah, just to pick up and confirm what Lynn had said, we've had a lot of obviously a detailed conversation about this in the exec management team, looked at the supporting statements, and also it's been taken into the collaboratives. That's just a bit of further reassurance for the board in relationship to the statement particularly, but also the plan has been tested as well. So so again, I thank for everybody for the work that's gone into this. Thanks, Chair.
Thanks very much, Michelle. I mean, there clearly has been a lot of work put into this. I mean, every year there's a lot of work put into this, and I'm happy to support the assurance statement as well. Lynn, could you just sort of maybe mention before we move on, in terms of getting feedback about actually what happened, can you just remind us as a board what the process will be for that? Because obviously there's lots of areas identified and then mitigating actions. Some of those mitigating actions say consider doing something. How will we as a board or through the subcommittees of the board get the feedback as to what impact those actions made?
So internally for us, obviously, this fits very much alongside our daily escalation levels anyway. So that obviously through the OPAL reporting that you've heard me talk about before. So, and obviously there's escalation process that if the actions that we've agreed to put in place aren't having a desired effect, then that will be picked up at ICB system level. So, and we still have a daily call in place to do that. That will trigger then us obviously looking at, well, if that's not working, what do we need to do in order to improve our actions and response to that? So, and obviously I'll be reporting through to EMT on a very regular basis, as I do anyway, around those system pressures, to ensure that our plan is doing what we expect it to do, or if indeed it's not, what we're doing to mitigate that. And then obviously that will happen at ICB level as well through that process.
Yeah, I mean, and that's really, I mean, obviously there's a real time issue going on there about not just if it's not working, what you're doing. I suppose what I was thinking about, you know, when winter's over and you start the process for next winter, you know, where in the board would we get assurance that, you know, not in the detail of the operation of what got escalated, but overall summary of what worked or what didn't work. I think that's what I was looking for really. At the end of this process, how do we sort of have a sense of what really changed?
As soon as winter ends, we start that review process of how effective our plans have been. So we do that as an organisation, as a trust, and then there'll be various ICB events, Caroline, that will pull that together as well. I'll make sure I reflect that in my coup updates as part of Michelle's CEO report. When we've got to those points, I'll reflect in that summary around what the key points were for us as an organisation. And then obviously we take that forward, as we have indeed done in terms of this plan. All the learning that came through that similar process last year has been reflected in our plan for this year.
Yeah, that I think would be really helpful. I mean, you know, you've got a job to get on with dealing with winter, but down the road, that sort of, you know, sort of almost, if you like, strategic level learning points would be, I think, really helpful for us to understand.
We never stop planning for winter, Caroline. It's an all year round event.
I do appreciate that, and I do know, and that dynamic engagement about what needs to escalate, what needs to be done in real time is a really important aspect of trying to make sure a problem doesn't become a crisis. So I think we all appreciate that, Lynn, and all the people involved in making that work. Okay, thank you very much. Can we therefore approve the Trust Winter Plan and Board Assurance Statement? Perfect, lovely, thank you very much.
Thank you.
Okay, risk management strategy, Sarah.
Thank you, Chair. The risk management strategy is coming for approval today. Obviously, this is an enabling strategy which supports our overarching trust strategy. There's been a number of updates in relationship to the previous strategy, which includes sort of the update of our risk appetite, and that was obviously the work that we did in one of our strategic board sessions. Obviously, the recommendations from the audit work that was undertaken, and then some further feedback received from the audit committee, and also obviously Stuart as one of our non-exec directors. And I've included within the front sheet the sort of changes that have been made following that sort of feedback and engagement, and that's around our risk appetite definitions, risk types, and revision of consequence as well. So happy to take any questions, but it's here for approval. Thank you, Chair.
Thank you very much. Any questions or comments?
Just to add, I'm grateful to Sarah and Oliver for taking on board the feedback that a few of us gave.
Yeah,
it's good to go. It's a little final tweak Sarah's going to make, but that's good to go now, I think.
Great, thank you. Ditto to Stuart's comments there as well. Okay, in that case, are we happy to approve the risk management strategy for 25-29? Thank you so much. We move on to the assurance reports, and we'll start with you, Dean.
Yeah, thank you, everyone. The report is there for a comment, and you can see that a number of those things have been on the board agenda today. Just a couple of things to highlight. I think this is one of those reports where there's lots of positive insurance on improvements, but still focusing on work to get further improvements, if you see what I mean. So, for example, you know, we are making good progress in terms of consultant appointments and reducing vacancies, but it still remains a focus of work for us to do more on that. And then also just highlighting just some issues on the horizon, really in terms of visa changes that are coming through and the impact that might have on staff, and a continued focus on that sickness absence, which we've touched in on a number of items here today, but also in terms of segmentation going forward. But happy to take any questions.
Thank you. Any questions to Dean? I'm just getting my right bit. No, thank you very much for that, Dean. 2 reports from Phil. Phil?
Yeah, they were on the meetings held on the 7th of August and 11th of September. We tend to have 2 meetings at this time of year to split up the annual reports and get them through in a timely way. Overall, we got great assurance. You've seen the PACE annual report, the safeguarding and the annual, you've seen those that have come to board, and there were several more. Just a couple of things to highlight. We'll be asked to have a particular look at the community mental health survey. The sort of response rate was only about 19%. The national average is 20%, so that is what happens. It came through quite late. This is not particular to our trust, but I mean, we're already in the cycle of resurveying. It started in September. So we focus looking at on the action plan and getting next year's report sooner so that we can focus on the areas highlighted. There were 4 areas that were in the lowest quintile of the report, which was, do you have a care plan? Do you feel in control of your care? Ease of getting through to the service, and does the support meet your needs? And obviously these are really important for patient experience. And so we were assured that it was a really great action plan. Whether there's time enough for change for this current cycle of questionnaire to make a difference, I don't know. The other area just to highlight is that we're asked by the board to have a specific look at falls. That there was an increase in prevalence, particularly at Whitby Hospital, with a couple of moderate harms reported, and the reports that we've got have assured us things are much better. We're going to continue to monitor it at Quality Committee, but it's going to be part of our business as usual. I'm happy to take any questions.
Thanks very much, Phil. I can't see any questions there. I attended actually the meeting where we went to the annual reports. It was quite interesting because having all the annual reports there, because I would say one of the things, Phil, that we sort of landed on as well was that within each of those annual reports there was some outstanding presentation of information in a really clear way. And I think one of the takeaways wasn't it, that actually if we can get some consistency or some approach to these annual reports, which will make it easier to read for a start, but also the outstanding elements that individually are contained in different annual reports, we make that the norm for the sort of structure of these things. So I think that was a really help. Seeing them all one after the other was quite a helpful takeaway, I think, from that, wasn't it?
It was, yeah.
And so I think obviously operational staff at that meeting took that away as well, didn't they, Sarah? Great. Okay, anything else? Great, thank you for that.
Sorry, I've got my hand up.
Oh, sorry, Michelle. Apologies. Sorry, Michelle.
It was on that bit. Yeah, I mean, there is a branding centre, as I think we spoke about in relationship to annual reports, but we've already started to pick that up. What has been mentioned, just to say that we've already started to follow that through in relationship to trying to get some standardisation. They are fairly standard because obviously we've got the branding centre, but we took the point back and we've already started to progress that. So just to give you a bit of reassurance on that, Caroline.
No, I know it was takeaway. I just wanted to, for those who weren't there, that was one of the things we could very clearly see looking at these different reports. Okay, moving on then to Steph, Mental Health Ledge.
Thank you. Just a couple of things to highlight really from the committee. One was a deep dive into community treatment orders, which we've been wanting to do for a while. That really gave us some assurance around how we benchmarked, although there's very little external information, but also how we fare in terms of race and gender, which are within expectations. And the current practices and processes have recently been reviewed, and we've got some better performance data now around CTOs. which are a really useful tool in managing risk within the community. One area of concern and risk that we identified was in relation to deprivation of liberty safeguards. It's basically you might characterise it as a crack between the trust and local authorities, down which people may fall on occasion. It has been clearly identified for some time, and will continue to be closely scrutinised and addressed. Exec team are well aware of it.
Is that a growing problem, Steph, or a problem that's just there all the time with this sort of hook up with the local authorities' role in this?
It feels like a problem that's been there for a long time. I don't believe it's growing. It's just coming to the fore a wee bit more. Is that right, Kwame?
Yes, actually it's going down. So we've worked with Hull Council very, very well, and Hull Council are prioritizing every patient that it needs assessment with us. We need to do some work with East Riding. There is a new East Riding lead for that, and I'm writing a letter formally to them to say we need to do the same work we're doing with Hull. We put it on the risk register. If we do the same work with East Riding, I suspect the risk would reduce rapidly.
Oh, that's really reassuring to know that work's underway. So good. So it's variation, isn't it, dealing with in that sense, and yeah, great. Any other questions to Steph? Great. Move on then to Stuart.
Yeah, thank you. Another positive audit report in August. Just want to bring out a couple of things. We had a very good discussion with the mental health division team about the way they do risk management, and we had a very kind of get the impression of quite sophisticated and mature way in which they're identifying and managing and dealing with risks in their division, which is really encouraging, I felt. The first batch of reports from the internal audit program this year once again come out with strong assurances, which is encouraging. And there's just one piece of work I need to alert you to. There's a new piece of legislation called the Economic Crime and Corporate Transparency Act, which places on us as a board a duty to ensure that we take all reasonable steps that fraud isn't committed on our watch by one of our teams. So not fraud against us, but fraud by one of our teams. It's highly unlikely to happen, but I've commissioned just a quick piece of self-assessment work, which will report back to my committee in November, just to make sure we're doing all the things that we need to do to keep us safe. That's it. Thank you.
Thanks very much. Stuart, any questions to Stuart on any of that? No, that's a very comprehensive assurance report. Thank you very much, Stuart. The October Board Strategic Development meeting, we've actually got our colleagues from NHS providers to come in to do a sort of phase 2 digital board development session for us. So as you can see from the agenda, we're putting some real quality time into doing that. I think some of the colleagues from NHS providers are making contact with some individual members of the board to get some thoughts and soundings on that. And we'll have our usual sandwich lunch with some members of staff, and then feedback would continue with a discussion from our board away day on the 15th of September, and some of the actions from that to talk about that, productivity outcomes you've got there. And actually, I think on this, the mental health commissioning transaction update, I'm not sure we're having that now, are we, Michelle? This paper's gone out. I think we've made a slight amendment to that. We'll still deal with that in part 2 discussions as we normally do. So that's the plan for that particular day. Everybody happy with that, Phil?
Yeah, it's just if we're having lunch with healthcare assistants or clinical apprentices, can we just think about how we engage with them? Because they might be a little spooked by how we normally do it. So I just maybe just some thought of how that's made more accessible, I think, will be really helpful with that staff group to get the best out of them.
Okay,
it's a good point, Phil, but we've had some good feedback actually, rather than being spooked in relation. I take your point, to be fair, but yeah, we'll get them sat down, I think, rather than stood up and what have you, if that's that helpful.
Yeah, thanks for that, Phil. It hasn't been confirmed yet, so we've still got to sort out. I think that's still being done about who'll come up. But it's a fair point. I mean, one of the problems, isn't it, about the room, with the room we're in, there actually isn't enough chairs once we get, you know, the staff members come in. So there's always a little bit of, you know, but yeah, anything we can do to make it, you know, as friendly as possible. But then all of you are such lovely, friendly people. You know, you play a part in all of that. So great, but thanks for that, Phil. Right, I haven't had any items to escalate presented to me. Any other urgent business? I haven't had any notification of that either. Review of the meeting. I actually think, you know, we've had some good discussions today, exploring certain issues. Thank you for bearing with my questions for sort of extra assurance as well. I think there's obviously some of the papers, there's some comments about some of the papers and the executive summaries and clarity in some of those areas, which also came out of our board development day that we had on the 15th of September as well, looking at, you know, particularly the front sheets and the executive summary about, you know, making sure they're consistent across in terms of how they are put together. Everybody felt they've had a chance to say what they wanted to say and ask the questions. Yeah. Any other comments then on the meeting itself? Okay, very much happy with that. Right. Okay. Therefore, we finished this meeting, and I suggest it is 12:32. Why don't we come back at, say, you know, 1 o'clock? Is 1 o'clock okay for people to come back for part 2?
Yeah.
Brilliant. Okay. Thanks, everybody.